consider, especially the diagnosis will be little later because most of the time it will be missed. So why do you have a recurrent UTI in VUR, vesicoureteral reflex? Most of the time it is because of high grade VUR, as I told, because of the dilated ureters, delayed emptying, and secondary PVR, which can cause stasis and bacterial growth. Or is it because of the secondary VUR? It's not the primary VUR, and we labeled it as prime VUR. Is it a secondary VUR which is causing recurrent UTI? That you have to consider. Or either could be ectopic insertion, or is a bladder diverticulum which is missed when we did the MCU. Should we repeat and check? Recurrent UTI, you have to, and if there is a recurrent UTI and we label primary VR, then you have to consider, or it is there a voiding dysfunction are there, then you have to consider UDS to label it primary or secondary VR. Bowel management is very important in VR, and to avoid constipation, because that is also can lead to persistent VR. And if there is a UTI, circumcision is to be considered if not done, and timed voiding has to be recommended. Needs early intervention in case of there is a recurrent UTI, deterioration in renal function, progressive scars and new scars are developing on DMSA. Either injecting a bulky agents or reimplantation has to be considered, even if the even at earlier age because of these conditions. So this is the how that VUR is managed, which has already been dealt. So once confirm UTI, voiding dysfunction has to be ruled out. Phimosis is there, you have to consider, and surgical intervention if there is a new scars or persistent high grade VUR after the or 5 to 6 years is there. What is other important thing is, even if there is a VUR is resolved, if there are scars are there, patient needs to be followed because they can develop hypertension or microalbuminuria, proteinuria can also happen, because if there's one kidney is poorly functioning or decreased functioning, the other kidney will take the brunt. So these patients still needs to be followed up. This has also been told. Neurogenic bladder, as we know that clinical examination is and careful history is very important. These are the occult signs what we have to look for. This appendage, hemangioma. This is the lipoma with the deviated gluteal cleft, hypertrichosis. So as I told, in these patients, renal function and renal scan has to be done. MCU and voiding diary, uroflowmetry has to be checked. UDS to look for the bladder capacity, detrusor pressure. Normal is considered less than 10, up to 20 is acceptable. More than 20, you have to be careful. And also the bladder compliance and bladder sensation has to be evaluated when we are doing UDS. The other condition is called what is non-neurogenic bladder, which is Hinman syndrome, has to be ruled out by evaluation, and the management is same. This is the pictorial depiction. This is a sphincter and this is a detrusor and this is a sphincter. You can see that if there is a overactive of both detrusor sphincter dyssynergia, what we call DSD, or it could be just because of the sphincter over detrusor overactivity and sphincter is normal. This is what variants we can see in the. So this is the whole spectrum of management in neurogenic bladder, either non-invasive, oral medication, as I told, alpha adrenergic blockers or antimuscarinic drugs. Beta 3 agonist has been tried and it is found to be useful. Even there are some reports where in children also it is found effective. Mirabegan, the new drug which has been used. Bladder drainage, non-catheter based, as Walserbaum voiding or timed voiding has to be counseled. And catheter based bladder drainage, CIC indwelling catheter or suprapubic catheter has to be considered. So, sorry. Minimally invasive Botox injection can be used to relax the detrusor if there is a overactive. External sphincterotomy, neuromodulation, sacral nerve stimulation, posterior nerve stimulation also been considered. Invasive procedure, bladder neck closure and the diversion. Catheterizable channels, Mitrofenov procedure if the compliance is good. Augmentation cystoplasty is the last thing, or non-continent urinary diversion, ileal conduit has to be considered. The other condition is the neglected ureteral stents. You can see this neglected which left for years, and this after removal you can see the discoloration and calcification on the stents. The sutures from the previous surgeries, endoscopic removal has to be considered. Stone, PUJ, ureteric or vesicle has to be considered using endoscopic or laparoscopic or open. In chronic kidney disease, patient can present with recurrent UTI because of papillary necrosis or infected cyst, especially patient who are on chronic dialysis. Fistulas, most of them will be dealt. Anorectal malformation with fistulas are the common thing. Even they can present post diversion, post colostomy. Also, they can present with the UTI because of the stools can be spillover and they can cause a feculoma. Acquired most of the time will be post intervention or because of malignancy. So fistula has to be excised and interposition tissue has to be placed, or sometimes it could be sexually acquired. Urethral stricture, most of the time it will be in children will be post surgery, most commonly hypospadias, which has to be dealt with dilatation. If not amendable, then resection anastomosis, or if required, graft to be used appropriately. BBD or DS, as ma'am told, bowel bladder dysfunction. Unknown etiology, bowel and bladder incontinence and withholding symptoms are seen. So, usually in toilet trained children without underlying anatomic or neurogenic abnormality. This is very important. Bad diet or poor fiber diet has been one of the conditions. Improper toilet schools where the toilets are not good. Other condition will be because of the this media or TV, video games, computers, postponing of urination, where which results in the detrusor sphincter dysenergia, holding behavior, confused or abnormal elimination, whether to pass or not to pass. The bladder is confused. Other things are social stress factors, dual working parent, single parent, children with many sports activities, or use of diapers has been also been seen. School, hurry back. So what will happen if the colon is loaded? Reduces the functional capacity of the bladder, provokes earlier voiding, provokes unstable contractions, provokes chronic pelvic floor spasm, which results in urgency frequency. Bowel holding results in constipation, abdominal pain, and can also cause difficulty in pass, labor, defecation, anal tear, fissure, and bleeding. So it's a cycle. So pain, retention of stool accumulates in the rectum, dilatation, then again which results in the pain. This is Bristol. I think all clinicians should keep and see this one. Treatment mainly retraining. It's retraining. Social incontinence has to be achieved. Multifaceted approach, integrated behavior and medical management, routine hydration, total fluid intake based on the weight and the age has to be considered. Diet: 5 servings of fruit and vegetables. Each serving has to be around 2 gram fiber or 20 to 35. That's been recommended. Happy bladder is an empty bladder. Even happier bladder is an empty one associated with the empty rectum. That's what it has been said. So this is what I say. The the food pyramid has been reversed. That's what I want. Thank you.
Thank you, sir. We now request the chairpersons to felicitate our speakers. Discussion. Any discussion, questions? Yeah. Anyone, questions?
Small confusion. All these years we have studied this urine report, culture report, suprapubic aspiration, single colony is also significant. But recent guidelines, little different is there. 10 to the power of 3, it is there. That's little confusion is there.
So still, so what you said is right. But in practice now, we will be. It's very difficult to undertake SPB sampling. So in infants, the cutoff is 10 to the power of 4. In older children, 10 to the power of 5. And 10 to the power of 3 is given for SPB, but even one bacteria grown is definitely significant. Yes.
Thank you very much, madam. And all the speakers have presented very nicely in a short time and covered both surgical and medical aspects. Thank you. Any questions?
Is there any scientific study on that?
Not scientific, sir. What is happening? I think because of diapers, usually they say trialing should start by 2.5, 3 years.
Yeah, 100%.
It is delayed.
Correct.
That is one reason they.
Yeah, I 100% agree. When we all grow up in the villages, nobody visited for BBD any clinics. Now we see so many people visit for this only.
Yeah, 3 to 4 per OPD, sir. That is correct.
Okay. Done. Any other questions? No. Okay. We now request our chairpersons to felicitate our speakers. Hogima. Dr. Appanna Iyengar. Dr. Prasanna Kumar AV, sir. I now request our speakers to felicitate our chairpersons. Dr. Anand, sir. Dr. Deepthi, ma'am. Thank you. We will change it, sir.
It's written, no?
We can change it, sir. The next section for the afternoon will be on bleeding neonates. The medical talk will be given by Dr. Saravanan R. Sir, Consultant Neonatology, Rainbow Children's Hospital, Bengaluru. Chairpersons for this session will be Dr. Shiva Prakash Sir, HOD of Pediatric Department, Government Hospital, Tumkur, and Dr. Kiran Sir, Associate Professor, Pediatric Surgery Department, St. John's Medical College. I request the chairpersons to come onto the dais, please.
So put that, it will come. I think Tumkur, this one. Drop it inside. Don't open from here.
Yes.
You're opening from here.
Yes, sir.
Change it means like you will be shaking. Better you drop it in this one. Suddenly, if this moves, you may not get it. Take it and drop it in the copy it and drop it on the desktop.
Yes.
ಜಾಸ್ತಿ ಆಗ್ಬಿಡ್ತು.
No, open it again. Click it.
Reject.
That's okay, just open it. And then this gets shaken, so it will get disconnected. Thank you. Give me a second. This one doesn't work. Yeah. Works. Hi, hello. Good afternoon to one and all. At the outset, I would like to thank the organizers for giving me this opportunity. And I would also like to commend the organizers for making a topic with both the neonatologist and the surgeons, because the relationship between a neonatologist and the surgeon goes a long way in ensuring that neonates go home safely. In fact, neonatal pediatric surgery has improved in leaps and bounds in the last 10 years, and a lot is to do with the neonatologist, surgeon, and the anesthetist all working together. And I think post lunch session is like batting in an afternoon pitch on a Sunday afternoon, where hitting sixes and fours is going to be very, very difficult, whereas the evening is going to be very, very easy, as we found 2 weeks back. Well, I like to keep it as interesting as possible. So I'm not going into the physiology and the pathology. I like to go in directly into the clinical scenarios. Neonatal bleeding syndrome, basically we may have a GI bleed or an intracranial bleed, a retroperitoneal bleed. It could be just a skin bleed or a mucocutaneous bleed. Last is the pulmonary hemorrhage. So irrespective of what are the clinical syndromes, two major questions are always asked. The first question is whether it is a well baby or it's a ill baby. And next is, are we dealing with a platelet problem or a coagulation defect problem? So this one chart I'll be going back and forth again and again. A simplified form is this one, where first question is it going to be a healthy or a sick neonate? And the DDs for healthy neonate is going to be these four, whereas sick neonate is those two. I would just run through a few clinical scenarios. Okay, the first scenario is a term baby born by normal LSCS, had a PROM of just 4 hours, which is quite acceptable. No other risk factors. Baby cried at birth. At 6 hours of life, the mother noticed blood in the diapers. Clinically, on examination, the baby has no pallor. Pulses are well felt. Per abdomen also, the bowel is soft. Tummy is soft and bowel sounds are heard. Now, this is the picture. The mother came with the diaper showing this one. She was in the postnatal ward. The blood investigation, again, these 4 investigations will be running through again and again through the entire session. The hemoglobin was 16.5, which is normal. Platelet 3.2, which is normal. PT was 15.5, which is an INR of 1.23, which is also normal, and APTT, which is normal. So whenever we have a neonate with bleeding, we run through this questions. Okay. So first is, did we have a family bleeding disorder? Well, no. Any chorioamnitic features? Not there. HELP syndrome? It was not there. And no maternal medication. So basically we have a term, well, bleeding neonate with absolutely normal labs. So the diagnosis here is, yes. So the diagnosis here, so for the residents out here, it is swallowed maternal blood. So this is the test which confirms it. Anyway, this clinical scenario is classical. This is a test which confirms it. This is the app test, which is very simple. All we do is just you can take now fetal hemoglobin resist alkali denaturation. So all you have to do is put sodium hydroxide, and if it hemolyzes, so the one which is brown is hemolyzed and this is normal. So if it is hemolyzed, it means that there is maternal blood in that. So a well baby with absolutely nothing, but the diapers obviously is quite scary, but this is a normal baby, nothing has to be done. Okay, so the first scenario is swallowed maternal blood. Okay, next scenario, again a term baby, adequate for gestational age, cried at birth, no other risk factors, baby on direct breastfeeding, thriving really well for up to 2 weeks. On day 15, the mother noticed streaks of blood in stools. Again, she went to a nearby doctor who reassured her. Okay, this was just streaks of blood here. I think you can, it's very quite clear here. 24 hours later, she was quite worried because the baby had a big bout of bleeding. So again, do we reassure this mother? Okay, this time we did a blood test. Hemoglobin was 14.5, platelets 2.6, which is still acceptable. PT was 16.5 against 15.4, with INR of 1.43, which is still acceptable. And APTT normal 45, CRP 2. In fact, in India, anything which is a little different from the usual, always rule out infections. You don't know anything, also still rule out an infection. And here we got an ultrasound done also. I'll come to that again. And it showed no features of malrotation. So the diagnosis here, a 2-week well baby with streaky blood and then had a big bout of bleeding from the gut. Direct breastfeeding, but still the diagnosis allergic colitis, cow's milk protein intolerance. Still some babies who are on direct breastfeeding, but the mother takes plenty of cow's milk, that itself can present as cow's milk protein intolerance. But here I would like to stress on getting this ultrasound abdomen done. The reason I'll tell you based upon the next one. Okay, so any well neonate with lower GI bleed, what all we think about is swallowed maternal blood, presence of an anal fissure, and allergic colitis. Okay, so second was a lower GI bleed. Now this is the third scenario. Again, a term baby. Here again on 10th day of life. Okay, in the night 11 o'clock, the mother had taken the baby to a nearby hospital, apparently for 2 episodes of vomiting, apparently non-bilious. So the doctor there had started on Domstol, sent the baby back home. Next day morning, they came to our hospital with again vomiting. The baby looked a little pale, but looked active. So the mother had the clothes also, the baby's wrappings also, and obviously you can see here it is bilious. So for residents and pediatrician starting, I would tell you always probe into the color of the vomiting, because sometimes you ask them the color, they say milky, it looks the same, or yellow also they say white in color. But sometimes you may have to show them a color and ask them, is this the color which happened? So this was a color which we know, oh, this is bilious. Obviously, this needs something immediate. In fact, we immediately got an ultrasound done. In the ultrasound room, the sonologist removed the diapers. There was blood and stools. And immediately the baby and ultrasound was done. And this is the X-ray which any surgeon will dread. Okay. Classically, this is gasless. Okay. And this video, I think no surgeon will want to see a video like this. Okay. So you can see that the surgeon is pulling out each bubble loop, and sadly, all the entire loop is gangrenous. So unfortunately, we lost this baby. So this was basically a malrotation midgut volvulus, where the entire gut was gangrenous. In fact, all he did was he untwisted, put it inside. We waited for about 48 hours to 72 hours, again reopened, but still the vascularity was gone, and we lost the baby, unfortunately. So what do we take home from this baby is not all vomiting in newborn is reflux. The color and nature of the vomiters has to be probed. Malrotation is definitely fatal. So even if you don't have an ultrasound immediately, at least an X-ray you can take. Ultrasound is the best to rule out. Okay. So don't just push away a vomiting as reflux, because reflux is very common. Okay. So that's about malrotation. Next is, this is again one more term baby delivered en route to hospital. So they couldn't reach hospital, but baby was born a term baby, cried well on the way itself. So they saw the baby and discharged the baby. The baby was feeding well, no other complication. On day 4, the mother noticed this kind of abnormal discoloration of the back. Obviously, it's a big ecchymotic patch with petechiae. And at admission, the baby had mild pallor, pulses all well felt with good color and tone. Okay. Here you can see that hemoglobin is less. So obviously it's quite ominous. Platelets also mildly low, 1.6. Now the PT is prolonged. INR is not measurable. APTT is 195. CRP is normal. Again, any infection, any bleeding in neonate, first thing rule out infections unless proven otherwise. Okay, here we got a term baby, non-institutional delivery, purpura with anemia and prolonged PT, APTT. So here we are dealing with, so we are dealing with vitamin K deficiency in bleeding. Okay, so this baby was treated with vitamin K and FFP transfusion. Okay, so vitamin K deficiency, basically what happens, what is the diagnosis is, PT is always more prolonged than the APTT. Sometimes APTT may be normal, only the PT may be prolonged. And more confirmatory is always the protein induced in vitamin K absence, though in India we don't have much of labs which do this. Okay, and the timeline of vitamin K deficiency, usually they don't present the first 24. Even if you don't give, they don't present in the first 24 hours. But if you have a mother who was on anticonvulsants, or she has liver failure and she's going to deliver the baby, now those babies may need 3 days of vitamin K. So they are more prone for early vitamin K deficiency. So they may need more higher doses of vitamin K. But the classical one where you miss the initial dose is from 1st to 7th day. And here you may have mucocutaneous bleed, and sometimes you may have umbilical bleeding. That's the common presentation. The late presentations are always in exclusive breastfed babies and those babies who are on prolonged antibiotic therapies. Okay, so then the next scenario, the 5th scenario I'm going to deal with is, again, a normal term baby, 39 weeks, non-consanguineous parents, no history of bleeding in the family, vitamin K has been given now. Okay, day 14, they did the circumcision. Post-op, they did circumcision outside, and night 2 o'clock, they came to us with post-op persistent oozing from the surgical site. So a surgeon also was involved, where he did not note any major bleeding vessels and all, just minor oozing was continuously there. So hemoglobin here was 14.2, platelets was little on the lesser side. Prothrombin time was normal, INR of 1.7, okay, 1.07. APTT was prolonged. So you got a normal PT with elevated APTT. Okay, so this is classical of hemophilia A, and we got the factor 8 done, which is severely low. So inherited bleeding disorders, if you see, hemophilia A and B are quite common. A is more common. Okay, so not getting into this too much. Okay. So what we need to remember is in hemophilia A, prolonged APTT with a normal PTT, and confirmatory is always factor 8. In fact, factor 8 in units usually is the adult levels. So it's not that it, whereas factor 9 sometimes may be little lesser. So when you're dealing with factor 9, okay, factor 8 is normal. I'm thinking about hemophilia B, then you have to look at the age appropriate cutoffs, because factor 9 is normally itself lesser in a newborn. Okay. Okay, so this is just a small ready reckoner for any coagulation profile abnormalities you have. So you got a normal PT with elevated APTT with everything else normal, fibrinogen normal, platelets normal. Then you're dealing with hemophilia A. So in if prothrombin time is normal, but only APTT is prolonged, you're dealing of hemophilia A. Hemophilia B also present similarly. Only the APTT will be prolonged. Next, you got PT elevated, APTT normal. Okay, so this is factor 7 deficiency. So factor 7 deficiency, I mean, factor 7 is involved in the extrinsic pathway. Okay, I didn't want to get into the entire physiology of it, but at least remember PT alone prolonged, APTT normal is factor 7 abnormality. Both PT, APTT abnormality happens in factor 10. Okay, now maybe a PT which is slightly elevated, APTT is slightly elevated, but the fibrinogen is less, is fibrinogen abnormalities. Okay, everything is normal, but still the baby is bleeding. That's always an unlucky factor 13. So in factor 13, what it does is it's a clot stabilizing factor. So in PT, what they see, okay, it's clotted. So it clots quickly, but what happens? This clot stabilizing factor is not there. So your clot strength is not there. So there are tests to look at the strength of the factors also, I mean, of the clots also. So factor 13 is always a bouncer where everything is normal, but the baby will be bleeding. That's factor 13 for you. Okay. Then comes DIC where everything is haywire. PT, APTT, platelets, everything is down. And last is in vitamin K dependent bleeding, you have a elevated PT when compared to APTT may be normal also, or not too much elevated, whereas the PT is very badly prolonged. Okay. The last scenario, okay, is a term baby. Again, no other risk factors, presented on day 4 with excessive jitteriness. So whenever baby presents jitteriness, any residents here, first thing is you check out the sugars. Next, you look out for calcium. Both were normal, but still the baby was excessively jittery. So an excessive jittery baby still get an ultrasound cranium done, and this baby had a grade 3 intraventricular hemorrhage. In fact, it is a term baby. Okay, term baby on day 4, which is unlikely to have such a bad bleeding. So when we got a labs done, we found the hemoglobin 9.4, platelets of just 32,000. PT is just mild, 1.48 acceptable, and CRP is also normal. So here we are dealing with isolated thrombocytopenia with a intracranial hemorrhage, I mean intracranial bleed. So we run through this entire thing, but at least what I make it simple. When the platelets are low, first think about any placenta insufficiency. So ask about history of pregnancy due to hypertension or HELP syndrome, perinatal asphyxias, and infection, and autoimmune disorders like ITP and SLE also in the mother. In fact, you're going to ask the mother's platelet levels also. In SLE or ITP, you get these trouble. But the most common and most devastating is going to be your alloimmune thrombocytopenia. Now, to keep it simple, alloimmune thrombocytopenia is nothing but a platelet counterpart of your Rh isoimmunization. Now, the mother does not have the placental antigen, so she is negative. The father has the placental antigen which he is given to the baby. So the baby is placental antigen positive. So the mother starts making antibodies to the baby's placental antigen. Okay, so what's platelet antigen? Sorry. So what's going to happen is the mother's antibodies are going to destroy the baby's platelets. So sometimes, okay, I'll just rush through. So you may have an intrauterine intracranial bleed also. The treatment is IVIG even in utero and platelet transfusion also. Okay, and this everybody has to remember. Your unit should have your cutoffs for transfusion as well as platelet giving also. So in NATE alone, they are a little bit more proactive. Sometimes first time it's okay, 25,000, but previous history of NATE is there, means you are going to give it 50,000. Otherwise, no bleeding. If the baby is not bleeding, you're going to wait up to 25,000. Have cutoffs in your unit for giving transfusion. That's most important. The last is, now this is all about the well neonate. When it comes to a sick neonate, there are only two important things. One is asphyxiated babies and another is septic babies. I'll just run through one baby with an asphyxia, which presented to us. A 36-weeker shoulder dystocia, got stuck inside, was limp at birth. came to us and baby started crying after that was referred to us about 2 hours. So the baby had a huge subgaleal bleed, and at admission in our hospital, the pH was 7.0 with a PCO of 60, and baby was intubated. So you can see the baby here who's quite pale and with a huge subgaleal bleed. Okay, so very important remember is to differentiate a cephalohematoma, a subgaleal bleed, and a caput. Subgaleal bleed is a huge space which can keep on spreading over the next 4 to 6 hours, and the baby can have shock and die just because subgaleal hemorrhage. Plus, these babies have asphyxia, which is again going to cause your DIC. So this baby had a worsening of subgaleal bleed with a bad INR also. So baby was given FFP and PRBC and platelets. Okay, this is a sick baby. So sick baby with DIC, this is the treatment cocktail. But still, after that, the baby was still having acidosis, and hemoglobin was still falling, and HB was still falling. Okay, so we got an ultrasound, I mean, a CT done, which showed again bleeding the liver and the spleen also. So these are all occult sites of bleeding, which we have to keep an eye on. Okay, the subgaleal bleed is not improving, but still the baby's hemoglobin is dropping, acidosis is worsening. Please search for these hidden sites also. The last, I would just rush into this one, though I think our hematologist spoke a lot about it. FFP transfusion, it's not that FFP is the magic cure for all the bleeds. Okay, in fact, there are very good guidelines to say the use of FFP is recommended if there is acute bleeding with coagulopathy. So just because there's a little bit of skin bleed, no need to transfuse. So acute bleeding with coagulopathy or a proven factor deficiency, then you are right in giving the FFP. And vitamin K deficiency you are going to give. Now, when are you going to give as prophylaxis is any invasive procedure, any surgical procedure you're going to do, then you're going to give the FFP, because there are times when, okay, baby is in sepsis. For FFP, I'll give, okay, it can be serve as for a volume expander. They say that the use of FFP is not recommended for treatment of sepsis or a volume replacement for hypotension. So judicious use of FFP is very, very important. In fact, in pulmonary hemorrhage, now, okay, whenever you're going to give the blood, always have a objective tool to assess the bleeding. Okay, just you see some bleeding from the prick side, don't jump into giving the blood. In fact, there's one thing called a neo bleeding assessment tool, which says when do you consider it as a critical bleed. Now you see a minor hemorrhage, any prink frothy bleeding from the ET is just a minor hemorrhage. That and all, you don't need to give FFP. In fact, pulmonary hemorrhage in neonates is more likely to be a cardiac dysfunction or volume overload, which is presenting actually as a pulmonary hemorrhage rather than a DIC. So what sometimes we do is, okay, the baby has a little bit of bleeding from the endotracheal tube. We pump in more and more FFP, which is again going to cause more and more volume overload. The heart is already failing, and you may have a massive bleed which may kill the baby, and we'll put it on the DIC. So many of the pulmonary hemorrhage is not from DIC. It's more likely to be myocardial dysfunction and going to be a volume overload. So be very judicious when you give the FFP. Have these kind of assessment scores. Okay, fine. That's it. Yeah. So always healthy versus sick neonate. That's the first question you're going to ask, and you're going to put it in which side it's going to come into. Swallowed maternal blood, think about app test. Allergic colitis is common in this era because a lot of CMP is going around. But always any bleeding, please don't forget malrotation. Surgeons will insist on that. Vitamin K dependent, both PT and APT. APT is mildly prolonged. Thrombocytopenia, alloimmune is common and the most dangerous. Okay, sick neonate, asphyxia and sepsis is the most common. Subgaleal bleed, please check the hemoglobin frequently, pulses, and watch for shock. Liver and spleens are sites for occult blood. Okay, asphyxia plus bleeding and coagulopathy warrants be judicious FFP transfusion. Okay, yeah, okay, I think I already, yeah, thanks a lot. Thank you so much.
Thank you, sir. Now we will have the surgical talk for bleeding neonates by Dr. Sadashiv Rao, sir, Senior Consultant, Department of Pediatric Surgery, DNB Pediatric Surgery Program, Regional Advanced Pediatric Care Center, Government Wenlock District Hospital, Mangalore.
respected chairpersons, my seniors and colleagues. Good afternoon and greetings from Mangalore. The topic given is a bleeding in unit surgical causes. The medical causes already has been discussed. So whenever we talk about surgical causes, we have to rule out medical causes. Red, wherever red, it's a danger signal. Even how many number of wagons are immaterial, but train will stop with the small red flag. So it's very important. So whenever this color is seen, or if you see a child with this much of blood volume loss, it will have peripheral and circulatory compromise. So this we need to remember. So these are the ones has to be picked up early by the clinician. These are already discussed these things, but I have enumerated some causes. So here if you see among the GI bleeds, so these are the only number of, the percentage of children who need surgical procedure. Exclusive breastfeeding is seen only in around 28%, because mothers usually will have a feeling that I have low breast, less breast milk. Let me give some extra milk, some powder milk, some cow's milk, or even as Dr. Saravanan told, this cow milk protein allergy. So that is the common cause of GI bleeds. Then other structures, renal and other things we need to look into. Coming to the various causes. So this is some of the things what we can enumerate in the foregut territory. So whether it presents as upper GI bleed, lower GI bleed is immaterial, but these are some things what we can see in the upper, foregut territory. Similarly, these are something we can see in the midgut territory, especially these two. Even though this comes under midgut territory, they can present still. They can present as lower GI bleed. So these are some of the things what we can enumerate in the lower GI territory, hindgut territory. So coming to some of the important topics, midgut volvulus. We just saw one video where he showed one child who is losing the entire midgut, which is incompatible with life. So you are going to lose the child, whatever you do at the end. So identifying this, wherever blood, upper GI, lower GI, wherever it is, identify, look for midgut volvulus, very important. Coming to necrotizing enterocolitis. So here what we need to remember is it can be single segment or multiple segments, and the indication, there are many classifications you may have, but whenever there is abdominal wall erythema and edema, maybe with the tenderness, maybe the best time to operate. By the time child comes with the perforation, peritoneal peritonitis and other things, the prognosis becomes bad. So an unwritten rule in NAC, once you operate, whatever the process of your NAC, which will halt. This is what our seniors have told. Another thing what we see is Meckel's diverticulum. 50% of our lower GI bleeds are from the Meckel's diverticulum. Bleeding can be torrential. We may be having so many investigations which we may be doing, but we have to see the feasibility which is applicable in particular given neonate, because the child is small, the structures are small. All those given in the literature, we may not be able to do it. And intersusception in a neonate is really rare. We see at a little older age group children, but here is a case report where the percentage what they see is very less. So bleeding per rectum was seen. So most of the time we, whenever we think of interception, we try to do some barium enema or some hydrostatic reduction. But what we need to remember in all neonatal, this one, they are usually secondary causes, and usually colon may not be part of interception. In such situation, the laparotomy and proceed with the manual reduction may be the answer. There are rare lesions, dewlafoil lesions, gastric polyp. Dewlafoil lesion is something which a person may get once in his lifetime. So we had in a little older child, we had one dewlafoil lesion like this, who presented with the torrential bleed. Gastroenterologist did scopy from above, below, couldn't make out anything, and there was no hope for the child. Anyway, child is dying. Let us open and see the peritoneum. So we opened. So entire gut was filled with the clots. So we made multiple enterotomies, evacuated the blood, then went on clipping bulldog clamps at around 20 centimeters gap to small intestine. Finally, we could see it was filling from the DJ. So it was coming from the duodenum. So from duodenum, how to look into? There was no way. So we went and opened the C loop. Entire C loop we opened, because there is no way we can make out. Anyway, child is going to die. Let us have a diagnosis. So that time we could see if near the ampulla of Vater was one artery was spurting. So which we could easily tackle, and the child went home. Now he is doing his engineering. So that's about dewlafoil. Then gastric polyps may not be very going back. Yeah, gastric polyps are not very common. Again, as a reference, what we have seen. So this is the dewlafoil lesion stomach, and they are operating gastrotomy because it's very close to the fundus. So it has to be sutured there only. This is a gastric polyp. Again, these are all very rare conditions. Rectal polyps. Again, we see rectal polyps with minor bleed. Torrential bleeds we don't see very regularly. But it's a small child, a 1 month old child, is a neonate presenting with, they still can present. But what we need to remember is abdomen is normal. You see the abdomen will be normal. So in these situations, once you evaluate, once it's a rectal polyp, once you resect it, the condition is corrected. The liver injuries, most of the time these are all birth injuries. Subcapsular hematomas more, that's what they say. And whenever there is hemoperitoneum, nearly around 35%, it is due to the liver injuries. So whenever such surgical problems are there, this is some 1957, somebody told risk of laparotomy in newborn is small. So if he is telling at that time, 1957, now 2023, we should not worry. So whenever we have a case like that, we should not hesitate in opening. So first case of liver tear, which was treated surgically successfully, is in 1934. This is another case where vaginal delivery, the soon after baby is delivered, they noticed baby is in baby was developing bradycardia. They took an X-ray, showed like this, showing hemoperitoneum, I mean free fluid in the peritoneal cavity. Whenever there is a bleed like this, or when the child is in shock, the easy way is umbilical vein catheterization. Tried that, it is going freely into peritoneal cavity somewhere. So there was no other time to see. So they just opened the child. I mean, the laparotomy was done. So they could see a torn falciform ligament with the umbilical vein, which was torrentially bleeding. The baby was saved. Second, splenic rupture. So both presented with some scrotal swelling. Even this one also had a scrotal swelling. So in this child, they had to go and do a splenectomy. Whereas here, they opened the scrotum. They found the hemorrhagic fluid was coming from the peritoneal cavity. From there itself, they a small mini laparotomy leg, gave a good wash till it was clear and there was no further bleeding. They maintained it as it is. So both child saved. But the thing is, what we need to remember, whenever necessary, one should not hesitate. This was a case of splenic pedicle disruption. So because of that, there was bleed. So with the various investigations, they could see there is a tear in the splenic artery, I mean the splenic hilum. So interventional radiologist put this coils into the splenic artery and the bleeding stopped. So spleen will survive because of the gastric, I mean short gastric vessels. So if we have facility for this embolization, I mean small child, you should have all these facilities, then it may be practical. So bleed need not be only into the peritoneal cavity. This is the bleed into the tumor. So nephroblastoma, bleed into the tumor and developing abdominal compartment syndrome. So there is no option other than going and removing this. So once the tumor was resected, and of course the later chemotherapy, everything was given. So another case, massive hematuria. So a tumor involving the pelvicalcial system, botryoid Wilms tumor. So again, of course, other pictures I have not put here. So finally, after removing this tumor along with the kidney, child was saved. So one more hemoperitoneum, massive hemoperitoneum. They could see some calcification, thought some teratoma. So once it was opened, they saw something like this, which was arising from the retroperitoneum. Finally, after removing this tumor, the bleeding was controlled well. So what we need to learn here, the first thing is surgeon should be daring. So many times you may not be able to get all the investigations, or the investigation may take time. So in the meantime, child will sink. So if necessary, child should not worry about anything. If possible, whatever is possible from his side, he should do it. Don't hesitate. Early diagnosis and intervention is very important, because the more the delay, more the failure chances, complications will become more. If you have thromboelastography, that is sonoclot, the company, they provide the machine. So with this, exactly you can make out what is going wrong, which clotting factor is necessary. So especially with the massive transfusion, what happens, already whatever child had, the clotting factors, the platelets, everything will get used up. And by giving our transfusion, so it will get diluted. Whatever it is there, it will get diluted. So finally, they land up in complications of massive blood transfusion. So to prevent all these things, I always say a surgeon should be surgeon. So he should not behave like a physician. He should be daring. So when necessary, it should be like Tendulkar. However, maybe the fast ball, you should be able to play without any problem. Thank you.
The session is now open for discussion. Anybody?
It was an excellent session oration by Mr. Saravanan and Sir Sadashiv sir. I just want to share one simple thing which we observed few years back. Usually after delivery, babies are given vitamin K and or zero dose hepatitis B on one side of the thigh. Following that, the baby developed a big, huge swelling, and the baby was so pale. And later we could do the APT, and it was diagnosed as a hemophilia A. In fact, APT was prolonged. So this was our one of the findings. Thank you.
Any questions from the house? Okay, thank you.
Thank you, sir. I now request the chairpersons to felicitate our speakers. Dr. Saravanan R. Dr. Sadashiv Rao, sir. I now request our speakers to felicitate our chairpersons, Dr. Shiva Prakash sir and Dr. Kiran sir. We'll carry on to the next session. The next session for today is congenital diaphragmatic hernia. The medical talk will be given by Dr. Rajat Atreya sir, MD, MRCP CH UK, CCT UK, Senior Consultant and HOD Pediatrics and Neonatology, Sakra World Hospital. The chairpersons for this session will be Dr. Sai Prasad sir, Consultant Pediatric Surgeon, Manipal Group of Hospitals, and Dr. Srinivas Murthy sir, Consultant Neonatologist, Aster CMI Hospital. I request the chairpersons to come on to the dais, please.
Am I audible or should I use the other mic? Other mic. Okay. Good afternoon. First of all, very happy and grateful to be here this afternoon sharing. Just one. Now it'll work. Okay. So I think of all the challenges that we together face as neonatologists and pediatric surgeons, no challenge is probably as daunting as congenital diaphragmatic hernia. So I apologize for keeping the presentation very simple and basic. That is only because the challenge is extremely complex. So when we are faced with extreme challenges, I think as intensivists, we always kind of filter it down to what is it that I can do well? Can I do it properly? So I think that will be the kind of theme for my talk. So the outline will be that we need to realize that CDH is a fetal condition. So it is a fetal cardiopulmonary condition. It presents to us in fetal life more often than it used to previously. And this is a fetal life, then again, provides a chance for parents and doctors to prepare for this. At birth, it has to be a managed event. So we become event managers at birth. A pre-op stabilization, especially with the pulmonary hypertension playing a major havoc, is the rate limiting step. Briefly, I'll touch upon surgery because a talk will follow mine. And I'll briefly touch upon short and long-term outlook. And then we'll take home messages. So just a brief note about embryology. What we know is that it's a diaphragm is a patchwork. It's a quilt of 2-3 processes coming together, where the pleuroperitoneal canals close and the septum traversum kind of fuses with the tectum, and then the pleuroperitoneal folds, and then we have this an intact organ. What is now evolving is that people are having a lot of animal models, rat models, to study why the diaphragmatic hernia happens, what is the cause, and what is the mechanism of this congenital anomaly. What is now becoming evident is that the hole in the diaphragm is probably, we are not sure whether it is the chicken or the egg. So now we think that for some reason, and there are vitamin A pathways blamed for this, that the lung bud, which is supposed to start forming, doesn't start forming properly. And when the gut is outside in the coelom and it has to come back into the fetus, at that point, the lung bud is not formed. So the gut kind of rushes in and then doesn't allow the diaphragm to form properly, is one of the theories. There could be a combination of both. This is especially true for the standard, posterolateral hernia. So what we now think is there is a double hit to the lung. So the first hit is the lung did not form properly at all. And the second hit is that the intestines and the gut contents came and actually occupied the thorax and did not allow the lung to expand and grow properly. So the lung takes a double hit. And we also need to remember that the lung and heart are very closely related. Although there is no proper congenital structural cardiac anomaly, we now know in a lot of CDHs, there is cardiac dysfunction. That is because the left ventricle is hypoplastic, the right ventricle is hyperplastic but extremely dysfunctional. And there are lots of cascading effects of both of this, which will lead to pulmonary venous hypertension, backflow. So I'll just spend a minute about why this is a cardiopulmonary condition, and secondarily a surgical condition. Okay, so the first component is pulmonary hypoplasia. So there is simply less number of gas exchange unit per square centimeter. So acinar hypoplasia is there and alveolar septa is very thick. And cardiac dysfunction, I just explained to you why this is. And pulmonary hypertension, which is the thing that we actually need to treat in CDH. So if there is one thing that we need to treat properly and get over it, is it's a pulmonary hypertension. So there are less vessels per unit of lung, abnormal musculature, and also what they have found is that the autonomic sympathetic parasympathetic balance that the vessels respond to is abnormal. So that's why some babies don't respond whatever you do, because they're not responding to in a normal way, and they have been like that in the fetal life. It's purani buriya, that it's not changed, just because the baby is outside. So, and I said this already, yeah. So now what we have covered is that we have a fetus in whom a cardiopulmonary condition is developing. More often than not, our fetal medicine or the obstetrician who has done the scan gives us an indication that there is a congenital diaphragmatic hernia in this baby. So how do we then start preparing? First thing is to get some information. The three things that we need to know: are there any associated anomalies, mainly to deal with aneuploidies and structural heart conditions? The second thing we all know is we want to know how bad is the lung. Okay, and a good measure of this is to look at the lung head ratio, LHR. Okay, so you simply you take a scan at the level of the fourth chamber of the heart and then compare it with the contralateral surface area of the lung, and then ratio it with the head circumference. But what we need to remember, previously we used to just do LHR, right? So 1.3, 5.6, less than 0.6, that's what we used to remember. But what we need to remember is diaphragm is formed by about 12 to 14 weeks, it is formed. But lungs and heart grow at differential rates from 14 weeks to 32 weeks. The lung grows about 14-fold to what it was, and the head grows only about 4-fold. So just comparing as a ratio doesn't work. So that's why they have given a observed to expected LHR. So this is a gestational age-based algorithm. And I'll come to the predictability. Simply to remember, if the observed LHR is less than 15% of expected, mortality is about 100%. Okay. So whereas if it is less than 25%, it is between 10 to 25%. This is where people have given lots of report, whether it is right side is better, left side is better, and that actually is not very predictive. The other thing which is predictive is whether the liver is up or liver is down. If the liver is herniated, then things are bad. If liver is in the abdominal cavity when they have scanned, it might be slightly better. So these are the things. And the only other predictor is if we have actually identified CDH before 25 weeks of age, then the lungs have not formed at all. So there will be severe lung hypoplasia. So why this slide is important is the most important uh, step in management of CDH is prenatal counseling, antenatal counseling. Now, because we know. So before we sit down for counseling, I think we should have all the information that we talked about in the previous slide on hand. Then only we'll be able to counsel the parents in a better way. And the second point about counseling is it has to be hopefully a joint sit-in of fetal medicine obstetrician who has a rapport with a family, pediatric surgeon, neonatologist, and the parents. And then often, I don't know what is your experience, but a pregnant woman at 30 weeks comes with at least two completely diametrically opposite expectation of CDH, and she's usually so confused. Somebody has told her everything will be fine, and somebody have told that you have to terminate. It's of no use. So counseling is a very important step. Antenatal management, I think the first step, people have tried fetal open surgeries, and you would have all heard about intraluminal tracheal occlusion to allow the lung to grow, the FETO procedure. What has evolved is in the last decade, we are much better at looking after CDH babies postnatally. So whatever outcome that FETO was able to give, probably we're giving better outcome as neonatologists and surgeons than fetal medicine interventionists are able to give. The European Registry of FETO also doesn't actually give a very good outcome. So then comes timing of delivery, antenatal steroids, mode of delivery, and place of delivery. Timing of delivery is very simple. Please deliver at 39 weeks, because babies born before 35 weeks with CDH do very badly. Steroids should be given for some reason if the baby is born before 37 weeks. Mode of delivery is a planned one because this is a staged event. So more often than not, it will be LSCS. Place of delivery. So people have debated whether these babies should be delivered in high volume centers. A high volume for CDH is anything 6 to 8 CDH repairs in a year is a high volume center. It's considered. And people have, that has some value. So, the well-oiled machinery is there and they're able to deal with complications. Whether the baby should be delivered in an ECMO center, the answer to that is possibly no, because that small percentage which go into ECMO actually don't do very well. And if you manage the other good chunk of babies with CDH, you would have saved a lot of lives. So US is very ECMO heavy, but Europe is not. So we can deliver if there is no immediate access to ECMO as well. So what I would put forth is that it is the neonatologist who walks the knife's edge, and before the pediatric surgeon actually picks up his knife. So we have to do a very, very tight balancing act. In the delivery room, there are very simple things. What we do is we run a mock drill. If a baby with CDH is going to be delivered, we do a simulation of the scenario and decide who is doing what and in what order. That really, really works. So we need to intubate the baby straight away at birth, insert a oro or nasogastric tube and start decompression. But when we're avoid bag mask ventilation, but when we are even using in endotracheal tube to ventilate for the baby, use a T piece with a measured PIP of no greater than 25. Okay, and there is only one place you can get preductal saturations, and that is the right arm. So that is where your SpO2 probe should be, and you be happy with low 80s, even 70s if the baby is starting to look well, and do not intoxicate the baby with oxygen. Previously, people used to, as soon as the baby is coming out, they would push, neuromuscular agent, blocking agents, and paralyze the baby. It has been found not to be helpful, probably deleterious. So no neuromuscular blockage and no preemptive giving of surfactant is required either. So then comes the fun and games. Once the baby comes to the unit, you have a really, really big problem on your hand, because you have lungs which cannot be ventilated and lungs which will not oxygenate. So what we have now found is we need to ventilate gently and allow for CO2 buildup if the baby is coping. So they've also looked at whether conventional ventilation is better than high frequency. A lot of units started doing high frequency ventilation and they thought it might be better, but it is actually not. Conventional ventilation should be the primary mode, is what has come out of research. As I said, pulmonary hypertension is the rate limiting step, and I'll go a little bit in detail about all of these things. These steps become important. So what we need to do, so I'm going to give some numbers here. So somebody asked the question in the morning session about invasive monitoring. What we need is definitely an intra-arterial line, preferably in the right radial, because that is the only preductal vessel that is ideal for monitoring. And that is the oxygen which is reaching your blood. So right radial artery, we usually place a indwelling arterial line. And a central venous access becomes very useful to give hypertensives, pressors, TPN, etc. So you can use umbilical vein for that, although it goes a little bit in a different direction. So numbers to remember, I'll just, if you want much more in detail, what ventilator settings and other things are there, but suffice to say, do not use high pressures. If you're having to use PIP of more than 25, you might want to oscillate HFOV. So aim for a preductal arterial saturation from the radial artery of 70, that's enough. And preductal SpO2 of 85 to 95, and postductal about 70 or more. And you allow CO2 buildup, provided the baby's end organ is fine. That is, how will you know? You have a pH of more than 7.2. Your urine output is decent. Your lactates are not very high. And your BP is in normal range. Maybe you need to still use some inotropes and pressors, but you are keeping the baby alive. So this is a reasonably good baby to have. But what often happens is, even with all these things, baby doesn't oxygenate. So what do we do next? So then we need to properly evaluate whether there is severe cardiac dysfunction and pulmonary hypertension, which will usually be the case. So the way we manage pulmonary hypertension is stepwise. So we optimize all the things that I've talked about, And if the oxygenation index is very high, then we oscillate. And if it is still not getting better, the next preferred mode is to give inhaled nitric oxide. That is a selective vasodilator of the pulmonary circulation. The other measures can also be used, and the candidates for ECMO is when they have failed these measures for about 4 hours and they're not improving at all. Oxygenation index, which is a measure of oxygen delivered to the ventilator setting used, is more than 40, and end organ failure is ensuing. Those are the candidates. If you have facility for ECMO, they can be counseled for ECMO and taken up for ECMO. A brief note about surgery, because there'll be a surgical talk following up. What is the benefit of our surgery, when to operate, and what is the best approach? So what is the benefit is not a philosophical question, but what I want to drive home is, just by returning the contents to the abdomen and patching up of the diaphragm, we cannot wish the pulmonary hypertension away. It will still be there. So you need to bear that in mind, that even post-op you might have issues with the baby. When to operate, the best time is probably 48 hours, not first 48 hours when we have. And the best approach, I'll leave it to the surgeon. The Euro Consortium has given some guidance that you can give a green light when these parameters are met. Fairly easy oxygenation with less lactate and urine output. So babies actually survive the surgery better if they're in this condition. If they're operated out of this condition, then it is a do or die. You cannot do anything else. You've operated, and you might have a baby at the end of it or may not have. Okay. So the other thing, I picked it up because there was a practice of neonatologists being very proactive and draining all the fluid that accumulates post-op, which is not required. So there's no need for draining the fluid. The empty space that the diaphragmatic hernia has created will fill up. And I'll conclude in a minute or so. And repair can still be on ECMO if there are, but the best result is after decannulation from ECMO. Okay. And supportive care, if you want to remember one thing, that you have to be fluid restricted. Okay. And the other thing, as Dr. Saravanan was mentioning, infection is a big killer, and we should not be in a position where we have done everything well, but the infection, we have sacrificed the baby to the infection. So infection prevention and control and judicious use of antibiotics is very, very important. So overall survival ranges between 50 to 80%. So when you do a bit of hair splitting, what I have shown in the earlier slide is the predictive scores. If observed to expected LHR is less than 25%, it is less. And if it is less than 15%, and if the liver is up, the survival is almost zero. So, and then it goes up. So the ones that are 80% are actually out of these ranges. And a lot of different data are there, but this is a data from Newcastle, which is published. They've compared their outcome 10 years prior to now, and they've shown a huge difference. But what for me as a neonatologist take home is, any baby who has required nitric or complex or complicated or advanced cardiorespiratory supports, their mortality rates is almost 50 times higher. Odds ratio is much more higher. So if you have a very difficult baby pre-op, that baby is going to be probably not, will not have a smooth sail. Long-term outcomes, I mean, these are the babies we need to follow up for a long time, because they can have everything from hearing loss, neurocognitive impairment, ADHD, autism, and then when they grow up, they might have scoliosis, chest deformities. Some might have persistent pulmonary hypertension, which we might have to treat for a couple of years also. So I'll summarize. The survival for in CDH now typically varies between 50 to 80+% in high volume centers. Increased mortality is there in lower gestations, complex cardiorespiratory support, need for patch repair. I'm told if, our surgical colleague will elaborate on that. And if there are any associated anomalies, we need to prepare ourselves financially, mentally, emotionally, physically for a very prolonged stay. And this is not a baby who you will change the settings and go have a cup of coffee. You probably draw a chair and sit next, because otherwise your legs will start hurting. So you need to stay next to the baby. Then a comprehensive fetal assessment helps in prognosticating and counseling. Counseling has to be multidisciplinary. Take-home message is gentle ventilation for neonatologists and pervasive hypercapnia. Pulmonary hypertension is a rate-limiting step. cardiorespiratory management should keep the baby alive so that electively CDH can be repaired. I think CDH is an elective surgery, but a neonatal emergency. So if we take home that message and we have a really stable baby for the surgeon to operate, we will be giving better outcomes. Thank you.
Thank you, sir. Now we will have the surgical talk on congenital diaphragmatic hernia by Dr. Deepthi Veppakoma, Professor and Head, Pediatric Surgery, Dean Research Wing, AIMS Mangalagiri.
Good afternoon. I'll move a little this side, otherwise you all can't see me and you will think it's Chat GPT. So the purpose of these talks for the PGs who are sitting at the back, some of us have sifted through a lot of literature and we are trying to summarize it because there's tons of information and it's very hard to know what we should be doing. So like Dr. Rajat before me, I'm going to deal with this complex problem in hopefully a simple way. And how do I just move slides this way? Yes. So when do we do surgery? I think this, just give me, okay, thank you. Yeah. Hey, I'm going backwards. All of us are familiar with this, right? So this actually has told us about patience, perseverance, teamwork, if you are looking at survival. And especially when the situation is very labile, we have to know when to step back and when to do. And as rightly pointed out by my medical colleague, this is not a surgical emergency. So I will quietly wait outside, let the people come out, like the people waited, the press waited for these chaps to come out of the tunnel. So from looking at it as an emergency, way back, I think in 1991, they realized that you need to stabilize and then operate. But coming back to one of the latest articles in 2022, it clearly says that delaying it beyond a certain point also has no significant benefit. So then when is the right point? Is it after 24 hours, 48 hours, 1 week? And in the West, there's immense literature about ECMO, and surgery after a week, 2 weeks. So I don't think we should really be going and waiting indefinitely because there is no exact readiness for surgery. So what we are targeting, or the timing of surgery, is after a period of stabilization. And this is just a repetition of the same consortium guidelines, the Euro guidelines, which was just presented. So I won't go into it in detail, excepting that we want the baby to be hemodynamically stable. So where do we operate? Right? So if the mountain doesn't come to Mohammed has to go to the mountain. So we have a patient who we already know is on probably inotropes, various supports, various monitorings. And if we cannot shift the baby to the OT, this is one condition I would say, let the surgical team go to the ICU and operate. Baby is already on a ventilator, so it becomes easy, it's intubated, so it is easy even for the anesthetist. And if you look at some of this, I mean, I put up this particular recent article that was published by our own pediatric surgery colleagues from Hyderabad, not for CDH, but for various other abdominal conditions, maybe even NEC and other conditions where they're safely operated in the NICU. So maybe for CDH, we should be open to having the surgery done in the ICU. What are the approaches? We have traditionally open approach. And of course, today we have to all learn, get trained, even in minimally invasive surgery. But when we talk about MIS, I think there's also a question of, if it is a laparotomy, I'm open, I'm doing a laparotomy. So if it is MIS, is it laparoscopy or is it thoracoscopy? So I'll start with just briefly going into the surgical technique for a conventional open laparotomy. And I'm assuming that we are dealing with the most common problem, which is the Boctelic hernia on the left side. So if you look at incision, this is again taken from Robin Smith. It is a subcostal left side incision, but many surgeons also prefer putting a transverse incision and a little lower, not 1 centimeter, maybe 2 centimeters. And the reason for this is quite clear, because we really don't know what kind of defect we are going to encounter. And if we need to use muscle flaps or some other supports, it is always good to have an incision that is slightly placed a little lower, because we are not always familiar with, or we don't have the availability of maybe a PTFE graft. So this picture, which is again from Robin Smith, shows that you can have defects of various sizes. But what I want to stress is that there are not many of us who actually do. These two articles are talking about doing an ultrasound and actually assessing the size of the defect. And maybe it is good if we have facilities to do that, because it will help us plan the surgery better, maybe even counsel the parents, and also prepare ourselves to know, okay, would I need to put a patch, or would I need to actually look at bridging that gap with more than just sutures? So going through the quick steps, when you do a laparotomy, we are reducing the intrathoracic pressure. For some of the maybe PGs who are here, you know that there is a negative intrathoracic pressure. So when you try to pull the bowel down initially, it's very difficult. So maybe putting in a small infant feeding tube, pushing some air through the defect into the chest will actually help you to reduce the bowel easily. And once you do, maybe this word hook is not the most ideal, but what I meant was you might have to use your finger or probably a malleable retractor or something soft to gently push the spleen and the liver down. We do not want to apply traction and pull. Spleen especially is very vulnerable, and sometimes just rough handling can lead to bleeding. So we need to be very careful with that. When you reduce the bowel, do not push it into the abdomen. We want to eviscerate, keep it out, and then complete the repair and push the bowel in. So since the bowel is lying exposed, it's always good to cover it with a warm, moist cloth or gauze. The other thing that we notice when we are operating is that anterior rim is very clearly visible, but posteriorly we don't see. And it is not always that a rim does not exist. There is an overlying peritoneal fold, and unless we open that peritoneum and unfurl the rim, you will not be able to clearly define the edges. And that is important because you want to approximate the diaphragm. Many times you might assume it to be a bigger defect than it is. Approximation is with non-absorbable interrupted sutures. And the picture there that I was trying to explain is when you have a defect and you are applying sutures, maybe a horizontal mattress, you want to scatter them up and down, not everything in a straight line. If you try to be very beautiful and symmetric and put sutures here, 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 you might actually rip apart or it might come away. So if your first suture is here, go a little away, then go there, come back here. So you're putting them in different layer levels. Coincidentally, I think we all look up the same articles and try to get information. So I have the same picture here, which is taken from that neonatology and perinatology for larger defects. And fortunately, that is not so common that we see big defects and we need to patch. And I have already covered this aspect about saying we can use the internal oblique and transversus muscle, separating it away from the external oblique and using it as a patch. So you don't always need to use a foreign body. Now, between these two, the advantage of trying to do it with a muscle flap is that it is going to grow with the patient. And when you are using this patch of PTFE or whatever, we tend to probably either make it too lax because you're scared it might strip, or it might be too small and it also does not grow. And we have seen in sometimes, just like we've seen in exome fallows, there may be a reaction to all this. It may extrude. There is a higher chance of recurrence also. Oh, this is this way and this way. Intercostal drainage, I would simply say most of us don't put an ICD, right? So you allow that lung to gradually expand. The air which is there will get absorbed. You also will see some amount of reactionary fluid that will accumulate maybe 24, 48 hours later, but that will gradually also get absorbed. So we do not want to put ICD. But the issue that surgeons face, where after all surgeons, and you might be tempted to correct the malrotation or the non-rotation because it's invariably associated with it. But if you look at literature, again, there seems to be a little confusion because a few articles do say that they were correcting. But by and large, the consensus is do not do anything, counsel, and let the parents be aware that this could be an associated problem. And this could be one of the reasons why there may be long-term intestinal obstruction and issues that they may encounter. So LAD's procedure is not a part of CDH repair is probably the take-home message for us. Abdominal closure may be a problem because you all see that these babies have a scaphoid abdomen, very small. And once you push all the bowel inside and try to close, it may be that they can end up with an abdominal compartment syndrome. So if you feel that there is a bit of tension, there is no harm in putting the subcutaneous and skin together and letting it be like an incisional hernia. It is not always required that you need a silo or something, but you need not do the facial closure very tightly. Then we come to minimal access. And as I said, is it thoracoscopy, laparoscopy? To me, it seems like a no-brainer, and I assume it's the same with you because you already know that the bowel is sitting in the chest. If you do a laparoscopy and put some more carbon dioxide, cause insufflation, you might actually be pushing contents. It's going to be more difficult to reduce it. So most of us, yes, we agree that it is a thoracoscopic approach if we are doing minimally invasive approach. Now, if you look at the pros, it is definitely evidence shows that the hospital stay does reduce and the mortality also reduces. Those are the ones, if you look at the, oh, sorry, which way am I going? The pros and cons, this is what a large systematic review is actually telling us about. But one word of caution when it comes to MIS, patient selection. Many of us are still in the learning curve. These are very small babies, they're labile. Most of them even tend to be low birth weight. So maybe our initial learning curve, it would be good to select older children, eventration of diaphragm, and patients who are a few months old. And once we get our hands going and we are comfortable, then look at actually doing it on these newborns with CDH. Carbon dioxide insufflation, of course, it has not been shown to make too much of a difference. So again, if you look at going into a few details regarding MIS, it is almost like a prone position. And you have that picture there from Robin Smith, which is actually showing you where the surgeon and anesthetist and assistant are. And this is a recent case that we had where we're trying to reduce. Of course, it looks like I'm poking through, but I was not really using much. Maybe this slide also tells us that we should not be using too much force and pushing the bowel down. You let that little bit of CO2 in the thorax, about 3 to 5 mm, it will gradually reduce the contents. We have to just be patient and wait. Post-op, we don't want to be in a situation where we'll say, I did a wonderful surgery, but patient died. I think that's our end point, is to see this child through and go home. And that is where I think, just as pre-op, the role of the neonatologist intensivist was very important. That continues post-op. It requires very close monitoring. And we have to be aware that any sudden deterioration would mean that there is a pneumothorax. This, what is honeymoon period, is a question all of you will get in your exam, and I would say read up about it a little more. I'm not going to discuss all the other rare entities and regarding fetal surgery or ECMO because it is just too elaborate. But the last thing that we need to know is about complications and post-op or surgical complications in the initial period. Hemorrhage, this is again taken from one of these recent articles, but hemorrhage is more an issue on those who have been on ECMO. Otherwise, abdominal compartment syndrome, we discussed about it. you can always have a recurrence that can happen either early, late, or even long term. And adhesive bowel obstruction or even obstruction because of non-rotation and malrotation is a long-term complication that we need to be aware of. So what I looked up and all this, when I went through, I realized there's a phenomenal amount of literature, but none of them are very high level evidence. They're all based on case series. And if we look at the volume load that we have in India, it's time that we all try to look at getting our data together, coming out with enough evidence from our institutions. We cannot rely, and even the systematic reviews there have articles that are probably 3 or 4. So level of evidence is always 3, B, C, D, K series. There is really no high level evidence. So why don't, I mean, to all youngsters here, let us start putting our data together, prospectively doing, because unless we have large clinical trials, we are not going to have evidence and we are not going to know how to treat these children better. So thank you. And I think after more than a decade of being on the side of the host, I'm actually standing here the first time in IAPS KSC and talking. So thank you to Dr. Subramaniam and team for that. Thank you.
Thank you, ma'am. The session is now open for discussions.
Thank you, Deepthi and Rajat. It was a fine talk. Just to complete your congenital diaphragmatic hernia, these are the cases which have been diagnosed and neonates call for us. And Rajat told that neonates walk on a fine knife and we come for an elective surgery. To be frank, sometimes these kids come at on 5 or 6 of age, same but diaphragmatic hernia or whatever it is, with sudden respiratory distress in emergency room, undiagnosed, asymptomatic. Sometimes our pediatricians have called us and radiologists reported as pneumothorax. And they call me for a chest tube incision. Why I want to just to tell, because the postgraduates, is that these diaphragmatic hernias can present anytime. They can be symptom free. They can present at age of 6, 8, or 10. They can present as acute emergencies. It can be because of this is twice in my life I've seen, is called for a severe pneumothorax. But only thing in our hospitals, for even pneumothorax, they have to call us pediatricians. This is a take-home message. Why I'm telling is that the pneumothorax they sent on a WhatsApp image, it showed a thin arc on the left hemithorax. This is it. Wait, don't put. Because in this era, pediatric surgery is taken over by pediatric interventional radiologists, pediatric intensivists, and as well as emergency physician. Everybody can take over our skills. But I want to tell to all the neonatologists, to all the youngsters, everyone, the brain of pediatric surgeons still remains. Please take our help. These are the cases where we come in for emergencies and we can save kids. Thank you.
Excellent point, sir. Because of the paucity of 15 minutes, so I think we just focused on the major this thing, but a lot of congenital anomalies also which have burst and blown in pneumothorax to everything, and then we always have a distress call to.
This pneumothorax is not due to.
So this is this misinterpretation of.
This is a stomach which is acute gastric dilatation. It is, if they put a chest tube, they create problems for us to do it. And secondly, another thing for a postgraduate is that you have to counsel these parents when we operate. These patients will have gastric atony for many days. They may have to have an NJ tube for long duration. This pre-op counseling has to be done. Otherwise, they will be questioning us because after the surgery, they will stay in the hospital for 1 or 2 weeks. Thank you.
Thank you, sir. Thank you, sir, Rajas sir and Deepthi madam, for a wonderful presentation. Just one question, I don't know, anyone can answer it. Regarding the vertebral problems that the babies face, the long-term prognosis of these kids actually, like maybe 20, 30, any study that you would like to quote on for the long-term outcomes, especially respiratory and bony abnormalities of these kids?
Again, as I said, the data set, as Dr. Deepthi was saying, is quite limited, but there are registries. Both US registries and European registries are there. I think I don't have the correct number, but I think they're in the range of about 20%. It's not too high, but I think somewhere in the range of 10 to 20% chest deformities and scoliosis of varying degrees. So, but what happens is, when these kids hit a growth spurt, spinal growth spurt, when they're young adolescents, that is the time it might start becoming obvious, and we would have lost them for follow-up. So that is the take-home message. Yeah. Thank you.
Thank you, sir. Thank you, ma'am. I now request the chairpersons to felicitate our speakers. Dr. Rajat Atreya, sir. Dr. Deepthi Veppakoma, ma'am. Sorry. I now request our speakers to felicitate our chairpersons, Dr. Sai Prasad. Ma'am told me, ma'am. Thank you. Dr. Srinivas Murthy. Thank you, ma'am. The next session for today will be on empyema thoracis. The medical talk will be given by Dr. Dakshayani, Associate Professor, Department of Pediatrics, Bangalore Medical College and Research Center. The chairpersons for this session will be Dr. Narayan Bhatt, Pediatric Surgeon, AJ Medical College, and Dr. Santosh Kurubet, Professor and Head of Pediatrics, JNMC, Belgaum. I request the chairpersons to kindly come onto the stage. Do you want this or this one? Whichever is okay. I'll make it. Okay. You just have to go this way, ma'am. Sliding. Pointer. Pointer, guys. Where's the pointer? You can use this to go front and back. These. Pointer is. This is forward. Okay. Yes.
So you must all be tired, I think, from morning. I thank the organizers, Dr. Subramanya, for giving me this opportunity. Actually, this is a very nice concept, holding both medical and surgical talks together, because ultimately we both work for the benefit of the patient. So, I mean, the child. So the topic, medical management of empyema thoracis. So coming to the history, there was an empyema commission formed into 1918 during the influenza pandemic. The major recommendations which were given were early closed pleural drainage, avoidance of early open drainage, sterilization and obliteration of the empyema cavity, and maintenance of the patient's nutritional status. So 100 years from there, the core principles remain the same, although many advances have taken place in the terms of availability of antibiotics or availability of diagnostic procedure, diagnostic imaging services like ultrasound, X-ray, or advanced surgical techniques like VATS, etc. But still, which intervention to use for which patient, still the dilemma remains. So if you see the burden of empyema, 0.6% of the pneumonias will develop empyema according to the literature in few articles they have mentioned. So it gives 3 per 100,000 children. According to the latest NFHS guidelines, wherein community management of, SANS program, they say 30 million episodes of pneumonia are occurring annually in India, of which 0.14 million deaths will occur. So you can see how much empyema we may be missing. So many predisposing factors are there. I won't go through all that. Poor oral-dental hygiene, aspirations, all those things. Especially in CP, cerebral palsy children, all that. So we'll now look at the terms. What is parapneumonic effusion? Collection of fluid in the pleural space in association with underlying lung infection is parapneumonic effusion. It is uncomplicated if the effusion is sterile, WBC count is low, and the fluid is free flowing without any septations. We call it complicated when there is invasion of bacteria into the pleural space, there is increase in WBC count and deposition of fibrin, septations and loculations are present. The late stage of complicated parapneumonic effusion is called empyema, grossly purulent fluid in the pleural cavity, plus minus presence of bacterial organisms on gram stain or culture. So etiology, the most common organism is pneumococci, Staphylococcus aureus, and H. influenza and Streptococcus pyogenes in immunocompetent hosts. In immunocompromised hosts, it will be gram-negative organisms or fungi depending on the hospital's prevalent organism. So there are 3 phases. It occurs in a continuum: exudative phase, fibrinoplulant phase, and organization phase. In the first 3 days of the parapneumonic effusion, the fluid is thin with minimal cellular response. If you do a fluid analysis, it will be pH will be more than 7.3, glucose more than 60, and LDH will be less than 1000. Gram stain and culture are negative. Later, from day 4 to 14, it will extend on to the fibrinopurulent phase. Here, the there is accumulation of a large number of cells and fibrin. So what happens is it becomes viscous and development of empyema. Here, the pH will be less than 7.2, glucose will be less than 40, LDH will be more than 1000, and gram stain and culture will be positive. After 14 days, fibroblasts grow into the exudates on both visceral and parietal pleural surfaces, producing an inelastic membrane peel that entraps the lung and prevents expansion. This is the organization phase. So, initially, child can present with fever, malaise, loss of appetite, breathlessness, hurried breathing, cough, chest pain, may lie on the affected side because of chest pain, because the breathing will cause pain. So, on examination, there will be respiratory distress, decreased movement, dull note on percussion, reduced breath sounds may be there. So, whenever a child with pneumonia does not improve after 48 hours, we have to think of effusion. So, if left untreated, it may lead to atelectatic lung, bronchopleural fistula, and rarely empyema necessitans. So, what are the investigations we do? So, there have been 2 guidelines for pediatric empyemothoracis. One is British Thoracic Society Guidelines 2005, and what I am portraying here is the IAP Standard Treatment Guidelines to 2023. So, blood investigation, total count will be elevated, CRP will be raised, hyponatremia may be there, blood culture, there is low yield. Pleural fluid investigation, cell count will be, there will be increased WBC, neutrophilic predominance, pH will be less than 7.2, LDH may be more than 1000, proteins, there will be exudate more than 3.5, glucose will be less than 40, and gram stain may be positive, culture and PCR can be done. So, X-ray, there will be uniform opacity of the hemithorax with mediastinal shift to the opposite side. Serial X-rays will be helpful in identifying the resolution of the illness. Ultrasound is a must to identify the nature of the fluid, whether it is loculated or free flowing, what is the volume of the fluid, and what is the optimal size for thoracocentesis. Serial ultrasound is very helpful. CT chest is not a must for every empyema case. When we have to plan surgical intervention, we may do, otherwise it leads to radiological exposure, unnecessary radiological exposure. It identifies underlying lung parenchymal necrosis or abscess, thickness of the pleura, and helps surgeon plan for the surgical treatment. So management, the sun should never set on a parapneumonic effusion. That means the fluid must be drained before we go home that day evening. So this is the various, whether we have to go for medical treatment or invasive procedure. This is the fulcrum. Here, if the short duration of symptoms, small effusion, then and patient is stable, we go for medical line of treatment. If the infectious symptoms and signs, respiratory distress is more, and the duration of illness is several days or to few weeks, and patient is toxic or unstable, we have to go for a invasive procedure. So, which invasive procedure? Here again, there is a fulcrum here. So, if there is small effusion, thin appearance on imaging, then we have to go for a tapping. Then, if the toxic or unstable condition, intermediate duration of symptoms, several days to few weeks, and CT shows multiple contiguous collections, pus is there on diagnostic tap, then chest tube may be this thing. Here and if there is contracted ribs, multiple discrete collections, all that, gelatinous appearance or visceral rim on ultrasound, we have to go for surgery. Here, this is affected by the availability of the whatever the procedure is available at that center or logistics. So, although they have described like this, I will make it very simple. In stage 1, where there is effusion, low cellularity, bacteria free, clearly flowing free fluid, we can give antibiotics, monitoring for worsening of worsening of symptoms, respiratory distress, all that. If the ICD, we can put if there is no clinical improvement or if there is increasing pleural fluid on clinical or ultrasound. In stage 2, Pleural fluid is high cellularity, bacterial presence is there, pH is less than 7.2. Here you can, the pH alone is not the criteria actually. pH may vary from one pocket to the other pocket in loculated empyema, and the pH may be affected by the heparin we use, and also an organism by Proteus. So you should look at the entire patient, the stage in which the empyema is. In the second stage, we can go for antibiotics. ICD is a must. Fibrinolytics or VATS if there is no improvement on ICD. In stage 3 or organization phase, there is reorganization of the fluid which prevents lung expansion. Definitely here VATS or thoracotomy is advised. So coming to antibiotics, as the common organisms are pneumococci and Staph aureus, we have to cover for ceftriaxone and cloxacillin, thinking that it is Staph aureus is sensitive to cloxacillin, and later we can modify as per culture results. Initially intravenous route, especially if we have to give in all patients. Duration of antibiotic 2 to 4 or even up to 6 weeks. Once the child is symptoms are improving, then we can switch to oral, depending on the clinical improvement and the inflammatory markers, all that. We may have to add vancomycin or linezolid if MRSA, we are suspecting MRSA, and clindamycin if there is soft tissue involvement. Supportive, paracetamol for fever, analgesics for ICD drainage, IV fluid in the initial phase, oxygen supplementation, nasal prongs or high flow nasal cannula NIV based on the distress severity, and incentive spirometry to improve the lung expansion. So coming to ICD, less than 7.2, and any distress which is not settling with antibiotics or increased pleural fluid in stage 2, we have to use with underwater sea drainage. Small bore ICD gives the same result as with a large bore ICD. A pigtail catheter also can be used. Ultrasound guided ICD placement is ideal. Mid axillary line, 6 intercostal space on the affected side. Daily monitoring of the ICD fluid and the swing is there or not is very vital. If suddenly, if there is more than 10 ml per kg in 1 hour, then we need to clamp it for some time, because otherwise, recently we had a patient who developed hypovolemia, low pulse volume and BP was low due to sudden gush of this empyema fluid. So we clamped it for some time and gradually we released it. Daily we have to monitor how much fluid is coming. If there is less than 1 to 2 ml per kg per day, or less than 10 to 20 ml per day for 2 to 3 consecutive days, and clinical and radiological improvement, then we may have to remove the ICD. So indication of fibrinolytics, if there are loculations or septations in the ultrasound early in the course of empyema till up to 7 to 10 days of illness, and now latest studies show that it is effective with more doses even beyond 14 days. It is instilled through intercostal drainage tube and mobilization is encouraged to aid dispersion. The adverse effects are fever, intrapleural bleeding, anaphylaxis, discomfort during intrapleural injection, transient blood staining of drainage fluid. Absolute contraindication is bronchopleural fistula and bleeding diathesis. Predictors of failure are pleural thickening, intraparenchymal abscess, and necrotizing pneumonia. So this is the this is what is given in the IAP standard treatment guidelines, urokinase and streptokinase. So for 3 days, 6 instillation in 3 days, 4 to 6 doses it is given. This is given in the IAP standard treatment guidelines. So coming to surgical, in the stage 3, when ICD show, despite ICD, the child has respiratory distress, persistent fever, then we go for surgical. Surgical thing will be dealt in detail by the next speaker. So whether fibrinolytics or VADS. So there is, both are, recent studies have shown that fibrinolytics is non-inferior to VADS in the treatment of empyema. So wherever there is VADS expertise is there we can go for VADS, because reduced need for re-intervention and short post-operative stay. Center where there are VADS facility is not there, they can go for fibrinolytics. So in our center, we have excellent pediatric surgery backup with VADS. So we are not opting for the this fibrinolytics. So the outcomes, good long-term outcome, clinical as well as pulmonary function, irrespective of the type of intervention, medical or surgical, and age at illness. So these two patient scenarios I'll be sharing with you. 1 year, 10-month-old boy who came with cold for 10 days, cough for 3 days, fever for 5 days, and pain abdomen for 1 day. On examination, he had a respiratory rate of 60. There was air entry was reduced. in the left lower lobe with a dull node. X-ray showed left consolidation, lobe consolidation with effusion. Ultrasound also showed effusion. Treated with augmentin, fever spikes persisted. Repeat X-ray showed left-sided empyema volume. This thing. Pleural fluid analysis showed there is a cells. So ICD was inserted on day 9 of admission, and but the fever persisted. So antibiotics were upgraded. Even then, the fever persisted up to day 10 or day 12 of even antibiotics. Fever persisted. So repeat X-ray was done, which showed pneumococele, and chest CT scan was done, which again pneumococele with effusion. So pediatric surgery opinion was taken. So they advised conservative management only, because the pneumococele, if during VATS, may lead to bronchopleural fistula. So that father was actually a police. Sir came and counseled very nicely. So he got convinced and successfully managed conservatively only. So he discharged with antibiotics for 3 weeks, and at discharge, few patients will be having dull note and decreased air entry. This is because of the pleural thickening. We need not worry about it. So he came back for follow-up also several times, and now the child is doing well. So the team management really helped her, because that father kept on asking, because he was affordable. Nimgagatta illa bere kade hogla anta. So sir counseled really very well, and it was managed. So this scenario, 7-year-old boy recently, just last month discharged, 7-year-old boy, fever of 3 days, cough, hurried breathing 1 day, and on examination there is increased tachypnea and hypoxia was there. X-ray, ultrasound all showed pneumonia with effusion. Initial analysis, pleural fluid analysis was 8,000 cells and protein 3.2. Patient was treated with Miro-Vanco for almost 18 days, I think. Initially, he was in ICU, NIV, then ICD drain was put. By 6th day, he improved. He came out of oxygen, all that. Antibiotics was continued for 18 days and then discharged. After ICD was removed on 7th day or 8th day, and then he was discharged. But 5 days after the discharge, he came back again with fever, cough for 2 days. Again, there were symptoms of decreased air entry and crepes in the lower left chest. This was the X-ray in the second admission. And this was the, how do I play this? CT. So this was a CT which showed patchy consolidation with air bronchogram in the left lower lobe. There was a well-defined hypodense loculated collection with enhancing pleura in the left pleural cavity, empyema. Again, we had to put a ICD, and we started on C-drive vancomycin and then changed to linezolid. 3 weeks we gave intravenous antibiotics, and then discharge, and home also on antibiotics. Before discharge, this was the X-ray done. There was almost a complete resolution, and ultrasound about 20 mm fluid was still there. So conservatively successfully managed. Yesterday also the patient had called me. Patient is completely asymptomatic and finished all the course of antibiotics. Will be coming for follow-up. Next. So coming to the prevention of empyema, there is something called a social action awareness to neutralize pneumonia successfully, SANS program, where they protect the children by good health practices, prevent the children from becoming ill from pneumonia, and treat children with pneumonia with appropriate treatment. So these are some of the IEC material, how to prevent pneumonia by breastfeeding, hygiene, keeping the child warm, giving vaccines, and reducing indoor air pollution, and identifying the symptoms of pneumonia: cough, cold, hurried breathing, chest in drawing, high fever, then danger signs, refusal of feed, and convulsions, and lethargy. If it is there, immediately it should be treated. To summarize, you suspect empyema in a child admitted with pneumonia, fails to respond to 48 hours after initiation of appropriate antibiotic therapy. Ultrasound is very useful in identifying and to know the progress of the child, and appropriate antibiotics for 4 to 6 weeks should be given. ICD in case of large effusions or worsening distress or pH less than 2. VATS in stage 2 not improving with ICD, and also in stage 3. And children should be followed up after discharge till they have recovered completely and the chest radiograph has returned to near normal. So this is the slogan of the SANS program. Thank you.
Thank you. Thank you, ma'am. Now we will have the surgical talk on empyema thoracis by Dr. Narendra Babu sir, Professor and Unit Head, Indira Gandhi Institute of Child Health, present Chairman of IAPS KSC. So you want this, right? So this is
Good evening. So I think the medical colleague has covered most of the things for medicine, but some of the points where which needs to be reinforced or we need to really say that it's good. So probably some repetition will be there, some points, but the rest of the thing will be surgical. Yeah, I think now the background is that since we work in institutes where we get some of the patients a little late referral is there, and then there is sometimes there are inappropriate treatment is there. So all these scenarios will lead to definite morbidity in the overall management of the patients. So the patients will have long-term stay in the hospital. Some of them may end up with a thoracotomy and related morbidity. So we are looking at how we can actually prevent this. So this one is most important is early diagnosis of empyema and proper imaging and appropriate management. Three points. If you properly manage it, I think most empyema patients will have good results. So this slide already, I think she already, Dr. Dakshani has already covered this. Like how do you diagnose the empyema? Whenever the patient is admitted with whatever the pleural effusion, and then you're given antibiotics. If there is no improvement in 48 hours, you have to suspect empyema and then work at this. And then like say, she's already covered this, but I would like to see, I would like to show you the images and how we can look at the staging of empyema in ultrasound. Ultrasound is a choice of investigation. CT scan is rarely required. So this is what the ultrasound says. This is the effusion. This is a stage 1, the stage 2, and stage 3. So this is a clear fluid inside the pleural cavity, echogenic fluid, and the already loculations are seen. And then this is loculations and septations have covering more than 1/3 of the pleural space. So if you properly done ultrasound, will give good information for like say the taking a call on management. And also a CT scan, as she has already told this, that is required probably whenever you're thinking of VATS, because it gives a better underlying the delineation of the underlying lung parenchyma, and also it helps to plan the ports depending on where the loculations are there. Yes, the CT scan, they're compared, many studies are there regarding ultrasound versus CT scan, clinical correlation, outcome correlation. So none of the studies, including 2005, the BTS guidelines, and also the thoracic surgery pediatric chapter guidelines also, there is no consensus on the outcome versus the CT score. So hence CT scan is not really required. So looking at the CT scan, they look at many parameters. One is fluid density, other one is a pleural enhancement, other than subcostal soft tissue thickening, and loculation and effusion shape. All of them are given a different score, ranging from 0 to 1 to 0 to 3, and the maximum score is 8. And this is what they say. This is the CT shape score. If the loculation is there, but it's a more of a lobulation than a loculation. So the intervening fluid collection, that pleural thickness is less than more than 10 millimeters. Here it is loculation is less than 10 millimeters. So this is what the CT shape scores talk about. And this is where we saw that ultrasound image showing more than 3/4 of loculations. This is the stage 3. So definitely there is no role for routine CT scan in these patients. Then the most of my talk will revolve around some of the recommendations from BTS guideline and also our own experience in managing these patients. So like as I already mentioned, the child is not well administration of antibiotic for more than 48 hours. Definitely we need to investigate and take a appropriate measure to intervene. And so if the effusion is enlarging, definitely we need to intervene surgically. And the chest drains is already covered. Like smaller chest drains is better. They have done a study that larger chest drains doesn't confer any advantage. Smaller drains are accepted well. They cause less pain. The patient can be ambulated early. As a surgeons, we always think that the bigger drains are better. Definitely no. So even pigtails also better to drain this fluid. And intrapleural fibrinolytics, yes, there is enough data at this point of time to say that so fibrinolytics and VATS are going hand, so almost in the same results. Being a surgeon, and we have seen that some of the patients who go on intrapleural fibrinolytics may need VATS to complete the surgery when there is no response. So the response rate is anywhere between the 90 to 95%, but even in 5 to 10%, definitely they require VATS. So we have a facility to VATS, better to do VATS. Then there is a recent addition is that like, along with the fibrinolytics, you can add DNase, which is like a mucolytic, which will make the pus also thin. So drainage is better, and the results are better. But when you have when you're planning for a VATS, so definitely this is not required. So if you're coming for a VATS, whether primary VATS or VATS following ICD, or like say the thoracotomy, depends on the stage. So if somebody is planning to do if there is no improvement in 48 hours, definitely we need to consider re-imaging, ultrasound, see the stage exactly, then take a call on that. So within 48 hours, you have to decide to whether to do like say fibrinolytics or not. If fibrinolytics doesn't help in 3 days, at the end of the 5th day, the patient should be coming forwards. So in our institute, we do the like say the most of the things we do post ICD VATS because our theaters we're not able coming to the theater, so we do less primary VATS. But given a choice, we would definitely recommend primary VATS. So like this is what the flow chart, like ICD, then fibrinolytics. If your institute protocol is for fibrinolytics, use of fibrinolytics. If there is no response, then consider VATS. And thoracotomy indication are common nowadays because we get the patient little early. So here, so this is the results of VATS versus fibrinolytics. Both are equally good, but in the fibrinolytic groups, there are patients who required VATS because the complete resolution is not there. So then also this paper, which is come from the Children's Hospital Seattle. So they looked into data from US. There are 14,936 children's data they looked into. So according to this study, they looked at 50% of them only require, even if empyema, if you properly plan, diagnose them early, they only require antibiotics alone. Rest of them may require ICD plus or minus fibrinolytics plus or minus VATS. So this is more important. This is early diagnosis and appropriate treatment. 50% of them will not require any intervention. And this is like say the primary VATS. If you do, this is a picture. So showing like say if you do primary VATS in a stage 2, so there are all this fibrin exudate on the lung. So first we do a clearance from the parietal pleura. Once the clearance of the parietal pleura is done, then we come on to the visceral pleura. So all this can be cleared properly, and by the end of the procedure, we'll see the lungs are nicely expanding and coming and touching the parietal pleura, nicely expanding. This is almost like say it will shorten the hospital stay, shorten the ICD stays, ICD days also, and also recovery is quite fast and uneventful. Then regarding this, like analgesia, whenever you do a fibrinolytics or like ICD or even VATS, so the recommendation is to have, if you give a proper analgesia, like say intrapleural bupivacaine insertion installation can be done, or a proper paravertebral block will help the patient to recover faster and postoperatively can be mobilized earlier, and also the improve the outcome. And then there is also something known as a uniportal VATS. This is where you have a 3 centimeter incision, muscle sparing incision, and you also insert some small wound protector, and through which you can use your ports. There's a telescopic port and also your instrumentation ports. And you, especially whenever there is little, let's say stage 2 and stage 3 empyema, stage 3 empyema, where you need thoracotomy, this can be an alternative position for thoracotomy, because this can give you an access to properly visualization. Also, you can use the open instruments, and you can plan to do the thoracotomy decortication. It gives a better outcome. And this is what, like say uniportal empyema, where your open instruments are put inside, under vision of the camera you can actually do a thorough decortication, both parietal and visceral, and it can lead to a good outcome. And this is the visceral pleura being removed in this is like same uniportal VATS. So good visualization and a small opening, the surgery can be done. So ultimately, also it does get a very low conversion risk. So it's as good as the results as good as thoracotomy and decortication if properly selected patients. There are some special situations where we have necrotizing pneumonia with empyema. Most of them will not require any surgical intervention. Prolonged antibiotic therapy and ICD is more than sufficient for them. And there is empyema and lung abscess also. In this situation, only manage the empyema, don't manage the lung abscess. Only give antibiotics to lung abscess, otherwise it will complicate the matter. There are situations where we have empyema with the bronchopleural fistula, which come late. Also, the diseased lung is there. In these situations, initially, after conservative management, whenever you want to go in and do a thoracotomy and decortication, that time, whenever there is a big bronchopleural fistula, consider muscle flaps. It will fasten the recovery and decrease the hospital stay. Otherwise, these patients, the BP bronchopleural fistula patients, may stay in the hospital for weeks together, and they may have a scoliosis, long-term morbidity also. Yeah, so this is how we have around 8 to 10 patients of BPF. We have managed the intercostal flaps, so they have done well. So this is the intraoperative photograph showing the harvesting of the intercostal muscle flap. Like say, expose both the ribs. You don't need to really do earlier. So rib excision is not required. So you make an incision in the top and cut into the periosteum, and also enter the pleural space there. Here also, just in the upper part of the rib, we make an incision, cut into the periosteum, enter into the thoracic cavity, isolate the intercostal muscle, along with the nerves and neuros, the pedicle, including the parietal pleura underneath. So then you detach from anteriorly and then roll it back posteriorly, and then do your decortication and whatever the debridement, and then do the intercostal muscle flap. So this will help the prevent the morbidities associated with the long-term hospital stay and the scoliosis. This is one more patient where we use serratus anterior muscle flaps also. Like the point is that whenever you require, if you use the muscle flaps, it will help in faster recovery. And also, so this is our own experience of fibrinolytics with versus VATS. Dr. Gauri Shankar has done the study. So he has done, like say, we have done around 48 patients. Out of that, 42 came for a study. 6 of them recovered purely with ICD only. In these results, they have, like say, we have 22 patients in fibrinolytic group and 20 patient VATS groups. So this 95.5% successful in fibrinolytic, and there are 90% successful in VATS group. So the point is that if you have access to fibrinolytics, it's equally good. So the conclusion was that they are equally good. The overall, the cost of the therapy was more in VATS group because of theater, the surgery, and also the CT scan. The cost was less in a fibrinolytic group. And also this is our stage 3 empyema. where we have done like say VATS for stage 3 empyema. This is our own Dr. Murali has written this paper. So here we had this, we have like say like a mini small thoracotomy, 10 centimeter, 13 centimeter probe, port is placed, and the same port is used for using like say the instruments which are like say the tendon tunnelers and also the worm forceps, and those forceps are used, and the thick peel is initially taken off from the parietes, and then later on the taken off from the lung surface. Overall, it has given a good results, almost like a thoracotomy. So it is feasible, safe, and effective. And a decision to convert for a thoracotomy should be optimal and should be on time whenever you feel that the procedure is not going on well. Otherwise, in selected patient, this is a very good procedure. And ultimately, I would say that like say proper staging, timely intervention is a key for good outcome in empyema. So involve pediatric surgeon early in the disease process, and also the VATS and fibrillatics are equally safe depending on your institute protocol. So we belong surgery, so we would preferably do a VATS, because we can avoid some patients who have fibrillatic therapy, which can some of them they have failure. So those patients also can be managed through VATS also. And definite role for stage 3 empyema, even VATS. So there is a even for stage 3 empyema, VATS thoracotomy is definite role is there. Thank you.
Yes, sir. Thank you, sir. The session is now open for discussions.
Nice presentation by Madam and Narendra sir. Any questions from the audience?
Sir, actually, very nice presentation and paper, sir. Appreciate that. We had some children where fibrinolytics were. I want to ask, ma'am, you have tried fibrinolytics, ma'am? We are not right. So what happened? It happened is we had a pulmonologist who wanted to push forth for the fibrinolytics rather than this. I think they tried a little late, and then it did not work. And we went in for a VATS. We were in a lot of trouble, sir. Most of the time we had to do a mini thoracotomy to do that. So what experiences?
So I think that probably the patients who have come to you is late. So the fibrinolytic would have definitely made some work there, probably not improve the clinical situation. Referral is probably late because if it is properly done an early surgery, so it has got equal results like a VATS, and most of the fibrinolytic failures can be managed by thoracoscopically only, unless they have underlying lung disease, which can suddenly we have, which is because most fibrinolytic patients they won't do CT scan. So they do an ultrasound. If there is some underlying lung pathology which is not picked up, then when you go for the thoracoscopy, then you suddenly see there is some air leak and all those things. Sometimes 1 or 2 patients were converted, but most of them can be managed with VATS only.
And what's your take on doing a CT before a thoracoscopy? Because sometimes we have empyema and also associated necrotizing pneumonia associated with that sometimes. So when we go in for VATS, we see areas of necrosis wherein we had to, that's what, because to close that things, we had to do a mini thoracotomy to debride and close the lung.
Yeah, so I think say if you are considering VATS, definitely there is a role for CT scan, because it definitely give you a good roadmap to underlying parenchyma, loculations, where to put first port and all those things. It will definitely help you. But it's not mandatory that you do the CT scan for all patients coming for VATS. And also a good sonologist
yes,
will be able to tell you about the
definitely.
lung parenchyma also.
Yeah,
So that thing. And some of the air leaks we see, especially small peripheral air leaks, you don't need to really close it. It will most of them will settle
those
down.
we do
Yeah,
that,
yeah,
sir. Yes, sir.
absolutely. Yeah.
Yes. Thank you.
Thank you. Take this. Take it, pull it.
In some cases where we had a severe febrile illness and necrotizing pneumonia, in such cases the CT will help, because it will show a vascular lung, and that in those cases you may have to go by direct thoracotomy. In those cases, that is the only case when CT helps.
Yeah. So if it is underlying, like say severe necrotizing pneumonia, So
those are sick babies and we are forced to do VATS.
So you go for a debridement. Anyway, you go for a debridement and not for a real complete recovery.
Thank you, sir. I now request the chairpersons to felicitate our speakers, Dr. Dakshayani. To come a little in front, sir. Dr. Narendra Babu. I now request the speakers to felicitate the chairpersons, Dr. Narayan Bhatt and Dr. Santosh Kurubit. The next session for today will be on lung malformations. The medical talk will be given by Dr. Srinivas Murthy sir, Senior Consultant Neonatologist, Astor Whitefield. The chairpersons for this session will be Dr. Prasanna, Associate Professor Pediatric Surgery, St. John's Medical College, and Dr. Anil Kumar PL, Consultant Pediatric Surgeon, Sakra World Hospital, Bangalore. I request the chairpersons to kindly come onto the dais.
Hi, good evening, everyone. So, I think it's the last session. I think everybody would be tired by this time. I'll try to be crisp and to the point, and I'll try to make sure that I'll be on time for this presentation to complete it as early as possible. At the same time, giving some valuable information regarding this some rare conditions that we see. We, as an in Aster for past 3 years, I think congenital lung malformations, we have managed somewhere around 6 to 7 cases, which we have managed, and CDH, congenital diaphragmatic hernia, somewhere around 12 to 13 cases we have managed in our unit. So it's an 24-bedded NICU that we are managing there. So let's move on to the topic. So these are the objectives of the presentation. I'll be first discussing about lung embryology and development and its associations with malformation. Second is I'll try to give a brief overview of some of the common lung malformations like CPAM, sequestration, bronchogenic cysts, and also I'll have some detailed discussions about tracheesophageal fistula and esophageal atresia. So this is the lung embryology. So 2 points to remember is the lung development starts at around 4 weeks of life. 4 weeks of life, and at that point there will be formation of tracheal buds and from the foregut, and that by the end of 8 weeks there is formation of bronchial segments. So this point you have to understand here. So from 8 weeks onwards, the embryogenic phase is completed. So following that, we have pseudoglandular phase, canalicular phase, saccular phase, and alveolarization. Alveolarization starts at around 36 weeks of gestational age, and it can go up to 21 years of life. We can see that pseudoglandular phase starts at around 5 weeks and up to 17 weeks. And in the canalicular phase, we see that it starts at around 16 weeks to 26 weeks, where there are formation of respiratory bronchioles actually. So this is a point where the end of it's end of conducting phase of lung development, and the saccular and alveolarization are the starting point for respiratory zones. So some of the morphological developmental lung disorders which are associated with certain developmental weeks of gestational age. During the embryonic phase, you have to understand that the lung is in the forming stage. If any insult happens during this phase, what happens is it leads to complete atresia. It can be in the form of tracheal, laryngeal, or esophageal atresias. Second is bronchogenic cyst. During the formation of tracheal bud or its elongation, if there is some part of that tracheal bud exits from its original form, exits from the original tract and sits in some different place, then it leads to formation of bronchogenic cyst. If the tracheal bud is doesn't get separated properly from the foregut, then it leads to formation of tracheoesophageal fistula. So there may be chances of pulmonary agenesis, and pulmonary sequestration is also one part wherein there is it starts at the embryonic phase. During the pseudoglandular phase, you can see that it starts at around 5 to 17 weeks of life. During this period, there is formation of kidney starts developing. By the 12 or 13 weeks of life, or the end of 3 weeks, we know that the kidney development will be happening during this stage. Any insult during this time will lead to renal agenesis and leads to pulmonary hypoplasia. Other disorders like CCAM, CDH, and tracheomalacia or bronchomalacia are seen during this phase of the insult is during this phase of the life. So during the canalicular phase, there are no significant pulmonary abnormalities that we can find, but very commonly seen disorder like respiratory distress syndrome can be seen at this age. Next is during saccular phase, also similar. And during the alveolar phase, that is 36 weeks and above, we can see lobar emphysema or congenital lobar emphysema, which starts at the alveolarization phase. So after knowing the association of the phase of development of lung and the disorders, let's move on to the components and its lung disorders. Some of the components like bronchogenic cysts have foregut component in it. The CPAM or congenital pulmonary adenoid malformation or lobar segmental emphysema is predominantly a parenchymal disorder. Airway component disorders such as bronchial atresia, tracheoesophageal fistula are airway disorders. Sequestration of lung is a disorder of both parenchymal disease as well as vascular abnormalities. So these are just an overview of what component is involved in each disorder. So let's move on to CPAM. This is one of the most common fetal lung lesion, and it is a benign lung lesion which has a non-functional or dysfunctional lung tissue that continues to grow. Most of these lung lesions are supplied by the pulmonary vessels, and that differentiates it from sequestration. And most CPAM are small and asymptomatic, and they disappear over a period of time. They increase in size till 26 to 28 weeks of gestational age. After that, either they decrease and disappear or they plateau. Some exceptional cases may grow faster and can lead to cardiac compression, heart failure, and fetal hydrops. So these are the conditions that needs to be taken care of. So these are some of the types of CPAM. The most common type is type 1, which originates from distal bronchi or proximal bronchioles. It is basically macrocystic congenital pulmonary adenoid malformation, and it has a very good prognosis. Most of them regress over a period of time. The second type is The grave prognosis is for type 0, and poor prognosis is seen in type 2, which are basically a microcystic variants. So antenatally, during the pregnancy, how do you assess the severity of this illness? So by determining the CVR ratio, that is CCAM, the mass volume ratio, which is being compared to that of the head size. So if it is more than 1.6, if this ratio is more than 1.6, then the risk of hydrops is severe. So these are the cases which has to be intervened. So what kind of interventions that we are thinking of? One is giving steroids. Giving 2 doses of betamethasone has shown to decrease the size of this mass lesion, especially the microcystic variant one. Second one is, if you have a macrocystic lesion, then draining that macrocystic lesion, or by putting a thoracoamniotic shunt, will help in relieving the stress on the heart. Some open fetal surgeries and C-section to resection. Immediately after C-section, we can go to resect the CPAM. That is also one modality of treatment. But I don't know about the fetal surgeries that we are following. Some cases we have seen putting thoracoamniotic shunts in few of these cases. So this is the same thing. I'm just put it in a flow diagram, wherein if the CVR ratio is more than 1.6, and if it is a macroscopic cyst, then we can go with these things. If it is a microcystic CPAM, then we can go with antenatal steroids. And if it is a solid one, then it's resection. So after delivery, if the baby is asymptomatic, just do a chest X-ray and a CT at 1 to 6 months. And we have to schedule the surgery between 3 to 24 months. The surgery in an asymptomatic child is indicated because of the risk of possibility of a cancer in these mass lesions. So it is better to take out these masses. Second is, one in a symptomatic cases, respiratory stabilization and emergency surgery is indicated. Now coming to pulmonary sequestration, it constitutes around 6% of the congenital lung malformation. This is also a non-functioning lung tissue mass, but it lacks communication with the lung, and it has blood supply from the aorta. Here you can see that aorta supplies the blood to the mass lesions. It is of 2 variants. One is intralobar variant and extralobar variant. Extralobar constitutes around 25%, and in the extralobar variant, it can be subdiaphragmatic also. The extralobar variant, you can see that they have its own viscera, but in the intralobar variant, they don't have its own visceral pleura. So based on the onset of sequestration, if it is very early onset sequestration, then it leads to intralobar variant. If it is a late onset, it leads to extralobar variant. And this is the differences. I'll not go into more details of these differences. One thing you have to understand in this slide is that the age of onset, extralobar variant is common in newborns and less than 6 months old kids, whereas intralobar variant is seen, or it is accidentally detected at an older age group. So this is a flow chart for the management of pulmonary sequestration. You can see, if you have fetal cystic lung lesion, if the color Doppler shows no systemic artery, then it becomes a CPAM. If it has a systemic artery blood supply, then we have to think whether there is any effusion or hydrops. If there is then we can go with shunt, and prenatal resection also is a possibility. If there is there is no effusion, then we can go with postnatal resection. And if some cases can regress on its own also. So these are some of the immediate symptoms, so immediate respiratory symptoms are a large mass which constitutes more than 20% of the chest cavity, or if there are multifocal or bilateral sequestrations, then that needs immediate treatment. The treatment here is either lobectomy or simple resections that we are talking about. So coming to the other third congenital lung malformations, that is lobar emphysema. 50% of the cases we don't know the etiology, and in 25% of the cases we have absence, incomplete or defective bronchial cartilage. Here it happens, this defective bronchial cartilage acts as a one-way valve and causes emphysema. So left upper lobe is the most common site for these congenital lobar emphysema. 50% of these cases are symptomatic at birth, and remaining 50% become symptomatic over a period of first 6 months. This is how the lobar emphysema looks in the chest X-ray. Clinical management. So in case of severe symptoms and age more than 2 months, that needs to be surgically excised. Mild to moderate symptoms can be observed over a period of time. The last lung lesions that we are talking about is a bronchogenic cyst. They are the result of abnormal separation of localized portions of tracheobronchial tree from the adjacent airways between 3rd and 24 weeks of gestational age. They can be seen generally around the mediastinum, and they can cause airway symptoms because of the compression. And that these bronchogenic cysts needs to be resected over a period of time. So last topic is on the esophageal atresia and tracheoesophageal fistula. Most of them know about this disorder. It is basically an esophageal atresia with a connection between esophagus and the trachea. So this basically results from the failure of two structures to separate during the division of endoderm or foregut endoderm. So there are various types in that. The common type is type C, which constitutes around 82 to 85%, wherein the lower part of the esophagus is connected to the trachea, and the upper part of the esophagus is a blind end. So these are the symptoms and diagnosis, and everybody knows about the diagnosis, the coiling of the Ryle's tube in the esophagus, that is shown here. And we should never use contrast in these cases, and it has bacterial association in 30% of the cases. So pre-op care, remember the pneumonic fossa, no feeding, upright position, intermittent suction, and antibiotic administration. We need to correct the electrolyte imbalances. Post-operative interventions, just what we use in our unit, I'm just highlighting it. We maintain the ETT in a precise location to avoid surgical site trauma, and we make sure that we avoid accidental extubations for these kids. We keep the bed elevated up to 30 to 45 degrees, and we do not manipulate the NG tube, and maintain the neck in the neutral position, and do not hyperextend the neck to avoid surgical site trauma. In addition to that, some conservative measures that like adding Rantac and antibiotics for 48 hours is a common routine. And day 7, we do an esophagogram, and once anastomosis is showing no leak, then we start on feeds for the child and increase over a period of time. So these are some of the post-surgical complications, and these are the prognosis of tracheoesophageal fistula. This is a speech classification. Babies with weight of more than 1.5 kg and no major cardiac anomalies have better survival rates. Thank you.
Thank you, sir. We will now have the surgical talk over the topic of lung malformations by Dr. Sandeep Kisku, sir, Professor and Head, Unit 3, Pediatric Surgery, CMC, Vellore.
Forward, backwards, and the pointer. Forward is back. Forward is a lower. Okay, and the pointer. Okay. Good evening, chairpersons and senior colleagues, friends. It's been a long day. Thank you, Dr. Subramania, for inviting me to make this presentation. I want to congratulate all of you for staying here for such a long time. Thank you, Dr. Srinivas, for the presentation before me. I'm going to do something that I'm going to ditch most of my slides. I know it's been a long day, and I'm going to give you something that will pique your interest and maybe inspire you to the next generation. I'm also going to do something very mischievous in the end, and you will easily realize that. Right. So, congenital lung lesions. Why do we need to operate on them? And we're going to look at a few cases. I have 5 short videos for you, so I hope it'll be worth your time here. Why do we need to operate on patients who have CPAM? Those who are symptomatic, clearly the answer is they need an operation. Those who are asymptomatic, they require an early surgery. And the word early here depends on who the surgeon is and how comfortable they are with operating. Now, why would we want to operate early? To avoid infections like infections, pneumothorax, and hemoptysis. I've seen patients with all of these, and some of these videos will show it very clearly. A lobectomy is curative and safe in experienced hands. And infections make surgery very complicated. There's a possibility of leak, blood loss, increased blood loss actually, a prolonged PICU stay, and not to mention increased costs. And compensatory growth occurs when done early. And Dr. Srinivas said lung can grow all the way up to 21 years. We see it mostly up to 8 years. So when done early, the lung grows well. And these two things are actually debatable. I'm not going to spend too much time on that. Now, what is the type of surgery we do for CPAM? We do a lobectomy. Could we do a segmentectomy? Yes, we could do it, but it is more difficult and has more complications. And segmentectomy is only done when multiple lobes are involved. And so the operation for CPAM is a lobectomy. BPS has been covered. I wanted to mention that most of our patients can have hybrid lesions, which are CPAM and pulmonary sequestration as well. And I'll show you a case. CLEs, again, Dr. Srinivas has covered very well. Bronchogenic cyst, we have had, we'll come to one beautiful case. Right. Shall we go to the video, please? This video will run for about 12 minutes, so I will stop talking after that. The video is on the, I think it's on the desktop, is it? Lobectomy, yeah, that's one. Yeah. Right. So left upper lobectomy. There's a CT of that child showing cystic lesions in the left upper lobe. And this is the position of the child's placed lateral, dead lateral. It's important in thoracoscopic surgeries. And the reason I'm putting up thoracoscopic surgery is because, is because this is what we've been doing for the last 3 years. And open surgeries you can find in any textbook. So it's important to see the hilum. And once you see the hilum, then you can start the dissection. There are some structures that you need to be, that need to be divided. The structures that are divided are the branches of the pulmonary artery, across the pulmonary vein that drains it, the bronchus to that affected site, and the bronchial artery. Now, it's very important that we have a clear understanding of the anatomy. And so a good contrast CT is very essential because you need to know the anatomy of the affected site and also of the normal site because you're going to preserve the normal site. Okay. So here I'm clipping the tributaries of the pulmonary vein. If you go proximally, you can get them as a single stump, but often in pediatric surgery, we don't go very proximal. It's mostly the adult surgeons who would go proximally. We do it a little distally. And so this is generally how most pediatric surgeons would operate. I'm using hemolog clips, and that's a ligature, 5 mm ligature. This child is 4 months old. The youngest we've operated is 2 months. So this is an upper lobe, and generally you don't expect to have any aberrant vessels here, though you have to know where the vessels are. When we come to the lower lobe, I will show you something more interesting. So the lingular artery, the artery to the lingula can take off from the interlobar vessel. And the interlobar vessel is from the lower lobe. And so it's important to recognize that, identify that, and preserve it when you're doing a lower lobectomy, and address it when we are doing a upper lobectomy. Well, that's the end of the operation here. We do a leak test, underwater leak test, post-op, post-procedure, intra-op. And if there are any leaks, we can close them either with hemolog clips, with metal clips, or even with sutures. Okay. So this child was discharged on day 4. And this is how the child looks post-op. So this is a left lower lobectomy, and this is a 2-month-old child. And you can see the classic appearance on the X-ray, compressed upper lung, upper lobe. And yeah, again, I said, particularly in pediatrics, in children, it's important for us to get the vision from the hilum. And that's why I'm mentioning this, move the port to be able to see it bang onto the hilum. It's not so much important when we're doing robotic surgery, which I will come to in the next patient. And yeah, so here you can actually see that there was some bit of compression. Those large lung cysts occupy the space in the thorax and doesn't give you space. So in CLE and in patients with large lung cysts, we need to compress the lung. We can burn it up and compress it, and then create space. So here's this is clipping the bronchus, lower bronchus, a branch of it actually. There's several branches are clipped. Yeah, small child, so I had to move around, go to another view, and then dissect the inferior pulmonary vein. So at the end, you have to separate the parenchyma. In smaller children, it's easy to use a ligature. In older children, we may have to staple them to avoid some air leak. That you will see in the next video. Yeah, so use a small tube, a 10 L cath as a chest tube once you made sure that there's no air leak. Yeah, this is a right upper lobectomy. And this is a 6-year-old girl with recurrent chest infections. And that's the CT. So even the 2-month-old child also had a lot of adhesions, which made it difficult. So I want to stress that these operations are well done, done better if you do them before the child is infected. So the earlier, of course, the surgeon should be needs to be experienced enough. and comfortable operating those children. And you need to have a team, an anesthesia team also that is willing to take up those cases. So you see these very dense pleural adhesions, and most of the bleeding that happens during this operation happens because of this. The dense pleural adhesion, the whole raw surface starts bleeding and oozing. It's very difficult. So here you see the upper lobe, the middle lobe, and the lower lobe, the affected upper lobe here. So these are taking the branches of the pulmonary artery, the conus arteriosus branches. Again, I'd like to stress that it's so important to know the anatomy of the chest and the lung before doing these operations. That's separating the minor fissure. That separates the upper lobe from the middle lobe. So the bronchus is I usually clip it with some Hemolock clips. The artery and vein can be clipped, or you can use a ligature. In older children, the bronchial arteries can be a little bigger and can be quite troublesome, and they need to be identified and dealt with. So there's again no air leak here after the operation. And this child was discharged on day 3. So you can see. This is an 8-year-old girl with recurrent LRIs and actually a hybrid lesion. You can see that they had an aberrant artery and vein from the thoracic aorta and from the hemiazygos. This is a robotic lobectomy, lower lobectomy. There's a lot of adhesions there. We are just taking down the adhesions. This is dissecting the abnormal vein and the abnormal artery. That's clipping the vein. This one is a fairly large arterial branch, and so rather than clipping it, we decided to staple it. And then the steps are almost similar. We dissect the pulmonary vein, inferior pulmonary ligament, to get the pulmonary vein. This child had a lot of adhesions, and it was difficult to collapse the lung. We had some anesthetic issues also. And so the structures that were readily visible to us, we were dealing with them. And it's okay to take the vein before the artery. Some people prefer to take the artery first, but it's all right to take the vein before the artery as well. So we are using ICG here, and this is the Firefly mode on the robot, Da Vinci robot, and that tells us that we have completely devascularized the lower part, and we have preserved the vessel to the lingula, because the lingular artery can take off from the interlobar artery lower down. We want to protect that. We don't want to unnecessarily do an extended operation removing the lingula. We are stapling the parenchyma to complete the operation. In a smaller child, we would just use ligature and then get done with the operation. Here there was an air leak, a little bit of an air leak, and so we're able to suture this bronchial stump. Right. And the child did really well and was discharged actually on day 5. That's ICG at the end to ensure the vascular, to make sure that the lingula is well vascular. So this is a 2-year-old child with a middle lobe that was hyperinflated, had recurrent LRIs. And here you can clearly see a subcarinal bronchogenic cyst. Here you see because of that cyst, the upper lobe was collapsing, and with the pneumo, the middle lobe was not collapsing, and the lower lobe was also collapsed because of the stretch on the bronchus. And so here's dissecting the subcarinal bronchogenic cyst. This is, of course, thoracoscopically. And at one point, we had to rupture it so that you could then dissect the posterior part of that cyst. Making sure there's no leak. And that is actually ICG fluorescence using the Karlström's Rubinia 4K stack. And that was actually possible because we had injected ICG into the groin pre-op, just before starting the operation. So these are some of our experiences. Not yet operated a patient with CLE, but I think Narendra Babu and his team have a lot of experience with that. Yeah, I'm happy to take your questions.
It was a wonderful presentation. So Dr. Srinivas has covered most of the pulmonary malformation within a short time. And sir has shown a beautiful surgeries, thoracoscopic surgeries. He made it look very simple. One small question to Dr. Srinivas. Like you said that the steroid role in the case of the cyst to decrease the size. Is the size or is the gestational age when you choose to give the steroids in those cases? The maternal steroid.
Maternal steroids. No? So it is for the microcystic variant of CPAM that maternal steroids have been found to be useful. And it is just a trial that is shown to decrease the size of that mass actually, especially in babies who have large CCAM, microcystic CCAM. But gestation wise, it will be after 26 weeks or something like that. But I don't know the exact gestational age.
Any questions from the audience?
Steroids or otherwise, if a UAG shows a resolution in some of these fetuses, they need again a postnatal EVSG or a CT scan to rule out the disease, because again they are there, the disease is still persisting there, and so-called the disappearance is almost nil.
Beautiful. It was demonstration in that robotic. No, so was it you're playing it a little faster?
Yes.
Huh? Okay. Thank you.
Yeah, I have a nice one, Sandeep. Just wanted that in the bronchus you use hemoclips or you staple. Is it okay? Because I'm not.
Yeah. So I've done now about 12 surgeries on this, and we only use hemolog clips. We prefer to use hemolog clips. 5 mm, either 5 mm or 10 mm. The robotic one is 8 mm, so it's 5, 8, or 12.
Yeah. Clips usually we use for vessel because that's collapsible. This is a cartilaginous. That's what I was asking.
If you're able to completely engage the trachea, you can actually bronchus. We are also using clips only. We don't have, let's say, staplers are not routinely available. We're using clips
The
only.
thing in the stapler is we don't get the enough room to manipulate, especially in the small kids.
Yeah.
No, that's
So
the
I
problem.
think you can manipulate it only after about 7 or 8 years of age. Before that, you just go little distal and you can clip them. And I've had no issues with clipping it. They may, when you try it the first time, maybe it doesn't engage well, but I think like
Yesterday, or you come and engage it again, it will close.
Thank you very much, sir. Thank you.
We now request the chairpersons to felicitate the speakers. Dr. Srinivas. Dr. Sandeep Kiskus. I now request the speakers to felicitate our chairpersons. Dr. Prasanna, Dr. Anil Kumar, PL. We now end the session for today. Thank you all for sparing your precious time. People who need transport to Ankit Vista Resort, kindly raise your hands so that we get your number.
ಮೇಡಮ್ ಸರ್ ನೀವು ಇದು ಬೆಂಗಳೂರು ಹೋಗ್ತಿದ್ರೆ ಬೆಳಗ್ಗೆ ಹೋಗ್ತಾರೆ ಬಂದ್ಬಿಡಿ ಸರ್ ಬೆಳಗ್ಗೆ ಸರ್ ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್